Good afternoon, everybody. Welcome to the SCTS and the Royal College of Surgeons of Edinburgh's joint webinar focusing on mental training and mindfulness for surgeons. The Society for Cardiothoracic Surgery have been running a pre-annual general meeting webinar, usually focused on the consultant members. And we've had a string of webinars in the last few years focusing on training the trainers, introducing innovative procedures, mentoring for surgeons. And this year's theme is on mindfulness and human factors. Likewise, the Royal College of Surgeons of Edinburgh within the surgical specialty has been offering webinars for almost 2 years now regularly. And as this year's SCTS meeting is a virtual meeting, we felt it will be appropriate to have a hub, and the hub is in the College of Surgeons. And the program today is not cardiothoracic specific. It applies to all of us as surgeons. So we've decided we will open it up to the wider audience of the fellows and members of the college with its international presence. We have a spread of focus in this meeting. We are kicking off with human factors and non-technical skills with our own specialty, cardiothoracic surgery. We then have a very interesting lecture from Professor Caroline Moulton from Toronto on what goes on in a surgeon's mind. We then move on to human factors and its impact on surgeon and patient safety, enhanced stress resilience and mindfulness by Professor Cartel Barras from San Francisco, and finishing off with increasing psychological safety in a team by Ben Tipley, who's the only non-surgical member of the faculty, but comes with a lot of experience and resource in mental training and working with teams. Without much ado, I'm going to ask my co-chair, Ms. Tan, cardiothoracic surgeon from St. George's Hospital, and the co-education secretary for SCTS to kick off the program. Carol.
Thank you. Good afternoon, everyone. Our first speaker for this afternoon is Mr. Mike Lewis. Many of you in the cardiothoracic community will know him. He is a consultant cardiac surgeon in Brighton and the only cardiothoracic surgeon in our faculty today. He's always been interested in education. He's our predecessor as education lead for the Cardiothoracic Society. But more importantly, he's been a faculty member on the NOTS course, which we've been running for our trainees in the UK since 2013. So for today, he's going to talk to us about NOTS, the cardiothoracic experience. Mike.
Thanks very much. I'm just going to try to share my screen, if it's going to work. Can you see that?
Yep.
Great. Okay. So thanks very much for that introduction. I feel very much like I'm the warm-up act for some much more erudite and experienced people in this field, but I think it helpful for us as a cardiothoracic community to reflect on where we've got to in the use of the understanding of this NOTS concept, and also in simulation in terms of helping us deliver that. And I thought it might be helpful, and Shrew's kind enough to ask us to talk about what we've been up to and where we've got to with our current experience. So I'm just going to spend 20 minutes or so running through where we're up to, and I'll be keen to hear your feedback at the end. First of all, I'd like to acknowledge the help of obviously the Society in supporting our course and taking it under the wing of the course portfolio for trainees, but also to all these individuals and teams who have really been instrumental in getting us off the ground. This has been a huge undertaking in terms of sort of logistics. As you'll see as we go through some of the slides, you'll understand why. And we've needed a really enthusiastic and helpful team to get that up and running. And if any of these individuals hadn't put their shoulder to the wheel, it wouldn't have happened. So I'd very much like to acknowledge their help, support, guidance, etc., to get this up and running. So this all started, in my mind, about 10, 12 years ago, where we had a moment, an idea, and I'll explain how that came about. We were I work in Brighton. Brighton is a relatively small cardiac surgery centre, probably not like anywhere else that I've worked, in that it's generally pretty friendly. People get on with each other. There isn't a lot of conflict, and sometimes some places I trained in, it was a little bit more confrontational. But Brighton usually pretty. We tend to get on with each other reasonably well, and it was therefore surprising one day when my trainee at the time had just been sort of progressing through the ladder of getting up to speed of operating, and I decided to leave the table and allow the trainee to continue the case as their first unscrubbed supervisor case. And as is always the way when that happens, you get that sort of someone gripping your elbow and saying, "Can you just come and look at this angiogram," whatever. I think one of the cardiologists just grabbed me, and I stepped out of the operating theatre for just a few moments. And then when I went back in, it was a room that I did not recognise. It was somewhere that I hadn't seen before in Brighton, really, in that there was chaos. There was shouting, and people were very upset with each other. There was all sorts of failures of communication. There was what would have been, as we'll come to see, a rather unsafe environment in terms of where things had got to. And I was staggered, I think, really, because, the trainee had been very much on the money as we've been doing things together. He'd been able to stitch things without any particular issue. And I was surprised that this had all happened. And it was really at that moment that I realized that we'd probably been doing things a bit the wrong way around. And I guess what had happened was that I was focusing on his technical skill and ensuring that he could safely stitch one bit of tube to another bit of tube. But what I'd probably been doing, and reflecting on myself around him, allowing him to do that, getting him to do that as well as he could, was to basically do all the other bits and pieces around the room that we all come to understand to be part of the picture of delivering an operation. And that moment of realization really was the foundation for me to start to try to put together something along these lines. And I started the work as a tutor when I was tutor for the society, and then was lucky enough with the new portfolio to be able to actually start to put things in place to allow this to happen. So essentially, it's summarized down to those two lines, in that, we all know this, but it was something that perhaps for the surgeons that trained in my generation, the focus was very much on your technical proficiency. Could you do the stitching bit? And then essentially you did so much of the stitching stuff for perhaps a generation above us that when you finished, you either could do it or you couldn't. And I've got a slide to illustrate that. But also to realize that, there is more to it. There's more to being able to just stitch one thing to another, and that the stuff around it, the soft stuff, the stuff that we've been brought together to discuss this afternoon, actually does really make an impact on the product that we can deliver for our patients. So this is a traditional sort of standard stuff, what we perhaps trained under, that you did all of these things, and when you could deliver all of these things and you knew about them, then you were then a surgeon. The more modern aspect is that we need to consider some of these factors, which I'll go into more detail later on in the talk. But in my generation, they were simply known as Factor X. And really, Factor X described it because we couldn't or didn't have the language to articulate what it was that we were looking for in terms of these aspects of care that were somehow described as some sort of magical thing that you either had or you didn't have. And that was, I can remember, used to decide whether people should continue in their training or not, because they did or didn't have Factor X. So there is happily now a much greater understanding of what these components might be, and also some way, because we can articulate them and because we can discuss them, we can actually train people in these things. And even if they don't have, as you might call it, factor X to start with, one can use simulation, as I'm going to mention later on, to help develop people's ideas around these things and hopefully therefore improve their ability to deliver a good, in inverted commas, operation. So we all know that cardiothoracic surgery is complex, and it basically is determined by all of these things that we can see to deliver good care. And then we need to put those things through communication and team working to get to best product. And why is it important? Well, we can see all sorts of references within the literature of problems where things haven't gone well. And if you look at things carefully, you can actually tease out that many of the issues we see in and around complex operations, complex procedures, actually relate to some of what we previously called factor X, soft factors, all those sorts of things that we've called it before. And so these are summarized as demands of modern medicine, but effectively are the very things that we've been trying to look at through the delivery of this course. And again, we've seen all sorts of things where, patient care has gone drastically wrong, but not because someone couldn't use a 6.0 or a 7.0, but because something more fundamental in terms of communication or team working or whatever has gone wrong. Now, we've all seen that happen as a reduced stenotomy. There's a heart behind the sternum for those who aren't cardiothoracic community. That's not a good thing to happen. What's happened there is the saw has gone into the right ventricle as the reduced stenotomy has occurred, and that's going to take some fixing. But by the fact that someone has had time to take a photograph of that, it would imply, and it was the case, that actually, whilst that's an unpleasant development within the delivery of an operation, it's not the disaster that it would have been had we just gone straight into the right ventricle without any preparation. And so to understand that error or trouble can always occur then allows one to start thinking about how one can either prevent the issue, so what you might do to try to stop that happening, or if it does happen, to be able to mitigate it by having prepared yourself, prepared your teams, prepared the environment to allow what could be a very troublesome situation to be, in inverted commas, rescued. And so we thought we needed to think a bit more about how we talk about this to trainees, rather than that sort of rather unhelpful summary of it all just being down to factor X. We started to try to come up with some thoughts. So we went to the literature, and very much luckily for us, lots of very clever people had done some very good work on this. And this is from, as you can see, the College of Surgeons of Edinburgh and the Aberdeen group, and particularly with the help of Simon Paston Brown, who was one of the architects of this stream of work. We started to develop something in the cardiothoracic community that looked at these non-technical skills. And this booklet is available. You can download it on that link. It's an extremely readable and very applicable piece of work, not least most helpful because it's quite short and therefore has a ready application, I think. And essentially it asks us to think about non-technical skills using those 4 domains that you can see on the slide there. And by dividing up our thoughts and starting to think about what those thoughts actually might mean, we can then start to think about delivering Factor X education, which is what we were aiming to do. So if we break those titles down into further subtitles, if you like, we can then think about looking at each of those domains and having an educational process that helps us to get people to understand the impact of each of these factors on delivery of best care. And putting that together with some work that showed that by using team training and simulation and so on, one can improve outcomes for surgery for patients. We felt we were in a good position then to start to consider how to deliver a course for our trainees. So this is what we've come up with. We started with the cardiac aspects of that, and we're going to focus the talk on that because that's the bit I've been most involved with. But we've also, as I've said, had fantastic support from the thoracic surgeons, particularly Ian Hunt and Gianluca to start off with. But now, as we've developed the program, we've got some new blood in as well, and it's sort of going from onward to upward, really, as we start to really gain some insights and understanding into how this can help. But as you can see, we've set up a fairly complex environment, and as best we can, tried to simulate what it's like to be in a cardiac theatre. And it gets very well reviewed. They love it. They think it's a really good experience. For many of them, it's something they've never thought of before. The delegates are coming to this really de novo without having really read anything about non-technical skills. And so it's one of those sort of eye-opening moments for many of them, and you can really see it as you're delivering the course that they are starting to get and understand what it is that we're trying to get through with them. And as I say, we can make the environment look very realistic. And whilst that's important and helps the fidelity, the realism of the environment, and therefore helps them to start believing that what they're seeing is actually happening, and therefore not having that, well, I would do this if this was real sort of thing, but this is actually putting them on the spot and making them think that they are working in a high-tech theatre environment, and therefore getting them into the scenarios. It doesn't have to be that complex, but we have, as best we can, decided to try to mimic the theatre environment. So that just takes, I'm just going to take a little side step into simulation and why we've tried to make the course run through this simulation rather than just talking at them about it through lectures. We felt that it was important for them to actually experience the theatre environment, to try to allow them to then take it back to their real working lives and make it as real as possible. So we all know that simulation is not real, but it tries to give us as best we can through the experience an ersatz version of what might be happening when we get back to work. And we've all seen the Kolb cycle, and by essentially having a simulation, one can go round and round this loop without putting patients at risk. And therefore we've used the simulation tool through a relatively high fidelity experience to get the trainees to really get to pick up their learning. So having sort of done some background on it and on simulation, we felt that we could then build our course. And what we've done is we've taken each of the years that we have coming through in the ST5 for about the last 7 or 8 years. We've had 16 or so delegates, and we've split the day up into some seminar-based discussions, but also use of the simulation-based learning that I've discussed, both in cardiac and in thoracic surgery. In the cardiac side, as I say, I'm going to focus on that. We've used essentially a bypass simulation tool called Orpheus. which is a machine that acts as a patient. You can connect it up to a bypass machine, and then as you do things with the machine, the bypass circuit and the bypass machine will react to them as though it's connected to a patient, and that all can be all that output can be put onto a computer screen, so you can have an arterial trace, ECG, all those sorts of things. And we've designed a series of scenarios that allow us to emphasize the NOTS discussions that I've alluded to before. And what we've tried to do is to deliver a learning experience for each of those different headlines that then allows us to then have a discussion about the learning. And as we've been using this simulation technique, we've used the trainees to basically to feedback on themselves. And so we've been doing some training on feedback and critique, and using a debrief to discuss patient events. And so we've sort of tried to combine not only the sort of learning that they've got through the actual doing, but also through how to use these powerful tools of feedback to get the best from their team. And as it says there, we've really tried to make sure that it goes away from the technical aspects of delivery of care, because that's what in general people are most comfortable discussing. And so we will often get, but would you use a particular suture, or how would you do that particular technique? What would you do? And we are absolutely adamant we do not sort of allow those sorts of discussions, because that isn't what we're there for. There are many other courses that allow us to look at particular technical elements of how to do an aortic root replacement, whatever else. But this is about our use of the team environment and how we best get the sort of care going in terms of those aspects of care. So, as I say, we can build a very complex environment. We use the Orpheus tool to do that. And we also use the folk within the room to help us deliver feedback to the delegates on the course. But essentially, through use of Orpheus, we can do all sorts of things, and therefore allow us to simulate some of the sort of routine, or in inverted commas, routine disasters that occur, and allow us to therefore build scenarios to get trainees up to speed. We've given them some structure for their feedback because it is unusual for them. They're not used to it. And so we ask them to use these forms to help record their thoughts. And we sort of build them up from their first conversations, which are, well, that was quite good, to a really very structured debrief. And I think that's a very powerful part of the course, if I'm honest. I think it's a very helpful thing that they take forward to their working lives. So we'll bring them into the room, we'll talk them through how we're going to do it. We'll start using in terms of delivery of the course, we'll then start using our simulation techniques. We have a varied and experienced faculty. We're using video feedback, and we're using that structured feedback as well. Essentially, as a candidate on the course, you're parachuted into a scenario with your co-surgeon, and something will then unfold. They start relatively straightforward, but the complexity ramps up as time goes by, and we find that they very soon get into the belief that this is for real, and that they are in a real environment. And that helps them to then understand, because it becomes less abstract, they understand how their communication style or their situational awareness or whatever else it might be that we're trying to work on in that scenario, how that actually then impacts, because then they can put it in, it feels real to them. They then put it into the sort of real aspects of their day-to-day care once they go back to work. So we've captured as many as we can. We've offered it to all cardiothoracic trainees in the UK for the last 8 years. It's a highly popular course. We get consistently great feedback from them. I suppose my thoughts are, as I come to the end of my talk, are really the two things that I'd like to think about with you and perhaps discuss at our wash-up. is we know that it's good. We know that it does a good job. And we've always been thinking that we need to try to, other than having the sort of, yeah, the biscuits are great and I like the sausage rolls and all that sort of thing feedback, we'd like to be able to actually measure quite what the impact of this has been. Difficult to do, but anyone who's got any thoughts on that, I'd be very keen to hear. And then I suppose the other sort of more broad-based concept is where should we go with it next? We've probably, I think, as we've got more experience at it, we've found that we've over-technicalized it a bit. We've made it because that was comfortable for us when we built it. I don't think it actually needs to be that technical as we go forward, but we just need to now sort of think of the next steps and how we might use that. So anyone's got any insights or thoughts on that, I'd be keen to hear them too. And with that, I think I'll leave it there. Thank you very much.
Thank you very much, Mike, to give us this whistle-stop tour into the cardiothoracic NOTS experience. I mean, it's a great course and trainees get fantastic feedback, and NOTS now has become almost ingrained into our specialties training, and it's seeing how best we take it forward. There are some questions. The first one is, can somebody possess factor X and still be unfit to be a surgeon?
Well, I think that's, to my mind, of course, because it's not one thing or the other, is it? It's the whole package. You have to be able to work with your team, deliver the very best in terms of your communication, situational awareness, all the other things. But you also have to be able to do the technical aspects. And so I think, as I reflect, as we designed this course, I reflected on some of the people that I'd worked with, and there were those who were amazing technical surgeons who were, the very best of what one can offer, but weren't so good at the non-technical stuff. They still gave great service to their patients because with the one they overcame the perhaps deficiency in the other. And then there are other surgeons who had great non-technical skills, perhaps weren't quite as gifted technically as others, but still gave really great products. And I think you have to be able to recognise that there necessarily is going to be some accommodation between the two arms of this. But if you're completely deficient in one or the other of them, it's going to be a very, very tough journey for you to deliver good care for your patients. And so I think that having the opportunity to think about it and discuss it and to actually have some words other than factor X, which as you know, Shri, was something that we heard quite a lot as we trained, I think it's very helpful for us to be able to at least understand if there are deficiencies, to try to understand where they might be and then put some work in to try to help those, rather than just a sort of yes, no binary, you've got it or you haven't.
Thank you. Now I'm going to put two questions together. So one is, could this be adapted to incorporate the perfusionists and the wider team? And likewise, it is fantastic to train the surgeons into non-technical skills. What do you do about the wider team members, particularly the ones on the other side of the blood-brain barrier?
Yes, when we first came up with this concept, we thought that we would be parachuting a whole team into the environment. We would have a scenario which we would then play out for the team. And I think as we've gained an experience, we recognise that we would now be able to run that if that was what was needed or required. And in fact, we have done it outside of the ST5 course. We've done it through some of the other programs that we've run using the Orpheus. And so, yes, it's entirely applicable to team training or team assessment or team building or whatever else you want to do. We can do that, and we have done it. Of course, for the ST5 course, we're there to focus on the needs of the trainees. So we can build, design, run the scenarios to maximize their learning in that environment and to get them to sort of make the yards as fast as possible. But yes, it is very possible to run this as a team, for a team based assessment tool or development tool, if that's what's required. Of course, that would need resource in terms of us, the buying of the facility and all that sort of stuff. It's not free, so we'd have to find a way to do it. But we can certainly do it, and we have done in the past.
Thank you very much, Mike. And with that, we will move on to our next topic. We have Professor Carolyn Moulton, who's going to give us an overview of surgical judgment beyond cognition. So I first heard Carol in the same venue in a triennial congress when she gave this talk in Edinburgh, and was very inspired. And when we were putting this program together, we asked her, can you do this? And she said yes, but equally, well, it is my son's birthday, but I would like to do it. So Carol graduated from Australia, has then moved on to Canada. She's a upper GI and hepatobiliary surgeon, but the main focus is what goes on behind the surgeon's mind. She has the Moulton Lab in Toronto, which focuses on what actually surgeons go through when things go wrong or things go well, and how it has an implication both on the surgeon as well as the team. She's also on call, so she's trying to juggle a few things. And for all those young trainees and medical students who look at inspirational models, who are always told you cannot be a female medical student and become a surgeon, there is your role model. Over to you, Carol. Thank you.
Thank you. Now you can hear me, right?
Yes, we can.
Great. Okay. So I'm going to jump right into a story. It's actually similar to maybe on the other side of, Michael, what you had actually shared in your story. I was the second year PGY2 in this story, which is I guess the second year of registrar in Australia. That's where I did my training. And I was left to do an inguinal hernia repair by myself from skin to skin. And I was very excited in doing that. I thought I was ready. I felt ready, but I was very nervous. And I remember kind of every strand that I cut or cauterized, thinking, is this the right strand? Could this be that nerve or the vas, or, am I, in the right plane? But I felt confident, and I finished the procedure thinking that I did well. And I walked out into the recovery room and, shared with the patient as he was waking up, trying to, almost high-five him, thinking, I did this, feeling quite proud of myself. And he woke up in excruciating pain in his testicle. And I remember the feeling of, oh my God, I've done something terribly wrong. And I've never seen anyone in so much pain in their testicle after an inguinal hernia repair. And throughout the day, I was consumed by these thoughts of, I've done something bad. What could I have done? And ruminating over, every strand that I had cut. I remember exactly where I was when I had the thought that maybe there was something wrong with his other testicle, just, by fluke. And I happened to, destroy that last testicle that he had. And now I've rendered this poor young man infertile. And I remember going home thinking, thinking about it and not being able to engage in conversations with my husband, and waking up often during the night and calling and seeing how he is. And, finally at 3 a.m, I actually had to go in and said, I might as well just go in and see for myself, confirm that this patient is okay, and tiptoed over to his bed. He was sleeping soundly, and woke him up and said, I just have to feel your testicle. And I remember, he looked at me, like I'm a bit weird, but, I remember feeling that I am not cut out to do this. This guy was actually perfectly fine. I thought I had a complication. I thought I had done something terrible, but I hadn't. And he actually recovered fine, and everything was fine. But I remember this distinct feeling that I don't see this kind of reaction around me. And my life will be awful if I have these kinds of reactions and not even have a complication. So I can imagine the complications and the major complications that I'll have. You know, surgeons are confident, surgeons are capable, but I was filled with uncertainty and I had a lot of anxiety. So fast forward many years later, and I'm now a hepatobiliary surgeon dealing with complications much greater than that, but become very interested in this construct that we call surgical judgment, very interested in how we define it, how we view it, and how we teach it, and how we assess it. And I actually became very interested in one particular phenomenon that we called slowing down when you should. And this was a phenomenon that I started recognizing in the operating room as a surgeon and as a trainee and as an observer in the operating room. This idea that surgeons are pretty much in routine mode, expert surgeons are kind of going in and doing their thing, but every now and again they have to slow down and focus on the field a little bit more than they were a few seconds before. And I did a whole PhD around the slowing down phenomenon. And I pulled from the cognitive literature at this stage, and you can talk about situation awareness or cognitive capacity. I thought that judgment at this point was a cognitive phenomenon. So I actually went in and I studied the cognitive aspect of this slowing down phenomenon. And I think one thing spoke to me and has continued to speak to me. I probably think about this phenomenon or theory every day. It's this idea that we have an attention threshold. So we all actually operate within a certain box of attention. And you can see the box on the left or the right. A novice would spend quite a bit of their cognitive resources on performing an activity or thinking about a task. And so as you become familiar with something, you become much more expert at it. You develop cognitive scripts and schemas. And the amount of cognitive resource that it takes then as you become an expert to do the same activity becomes much less. So as you can, as you know, when you're taking a trainee through an incision or even suturing up an incision, a junior trainee would use all of their cognitive capacity to do that task. And as they become expert, they don't, and they're able to have conversations. If you ask a junior trainee a question, they often will stop what they're doing and then answer the question. And I remember as a trainee, someone saying, "Come on, you got to learn to do two things at once." Well, that person who told me that didn't understand cognitive capacity, because it's very important to start thinking about how much capacity it takes to attend to something. And then also in that vein, what do we do with the spare capacity that we have? And how do we actually use that? And if you flip those boxes around, if you're now the expert on the left-hand side, mostly what you're doing requires very little primary activity. You have a larger spare capacity. But then you encounter something that's critical, you encounter something that's uncertain, and you slow down. And now you're actually recruiting additional cognitive resources to attend to that task. And you can see this play out and even feel it by understanding how you look at people's spare capacity. Surgeons will be engaging in a conversation 1 second, and then they withdraw from the conversation, or they tell you to be quiet, or the music in the room starts bothering them. And that's because they've transitioned into a more effortful focus where they've needed to recruit that spare capacity to focus on what they're doing. And I've learned a lot about mindful practice, how we actually sometimes get into trouble, and where is our spare capacity? Are we actually using it to attend to the right things? Sometimes it's important to think about the kind of metacognition, how we think about thinking, but what are we actually using our spare capacity to do? And I always try to leave some spare capacity to ask some questions about mindful practice, like, am I in the right plane? Are we doing the right thing? And yes, you can sometimes even have some more spare capacity to talk and to listen to music, but we have to be very careful that we don't actually overdo the capacity. And I started thinking about this as in the moment. So I'm a hepatobiliary surgeon, and people do lap choles, which is our bread and butter. And in a second, they may put a clip across or cut across the common bile duct. And that's a very bad complication for the patient. And it happens in the moment. And I became very interested in understanding what's going on in that moment of practice when these mistakes are happening. Is this just a cognitive error, or are there other things that are going on in the room that's actually also important? And at that point I started understanding that judgment is more than just cognitive, that it is also cultural. The pressure that we feel sometimes to do something. It's also social and environmental, like Michael was talking about, in terms of how we control the room, or how the tone that we set. These all can impact the patient. It's also emotional and how we deal with stress. So I've actually spent the last several years of my research studying some of these other dimensions of ourselves, to think about what actually defines kind of expert judgment beyond the cognitive. As one senior surgeon said in one of my interviews, my efforts during these moments of crises were consumed with the anxiety I was feeling and intermixed with feelings of inadequacy, uncertainty, reputation, and ego. And so, as I said, I started then understanding that as a trainee who was experiencing a complication to an error, or not even an error, had an emotional reaction to my work. These things were unspoken, and I don't know why. And I don't think it makes us healthy to keep them without speaking about them. I think a lot of us actually are dealing with, the culture or fears that we are not able to actually talk about because of the culture that we're living in. And so I've spent some time, as I said, and I'll share with you a couple of studies where I've gone into this a little bit. My research is largely qualitative. It's where you need to study a social phenomenon that you can't count. So I can't quantify the stuff that we're studying. These things happen in the social setting. And so we have to find ways of going in and exploring and interrogating these kind of phenomena that we're interested in. So largely it's through interviews and observations. And I use a methodology called grounded theory. So I say, I'm interested in this phenomenon, but I will go and explore it. It's often for me with surgeons in the operating room through interviews and observations, where they will help me build up a framework to understand a particular phenomenon. And you take it back to the lab and you code data and you think about it. You look in other literatures to try to understand it. You then bring it back to the field. You understand it and refine it more. And then as you go along, you hopefully will have a framework that other people will understand as you talk to them. So the first study that I'd like to share is this idea that the issues of failure to slowing down. So when we actually ask surgeons to focus on or reflect on why they failed to slow down in their practice, so errors they may have made in the moment, what actually was happening, and getting beyond kind of the cognitive and understanding what's happening in that moment. Initially I created a list of factors that contributed to error, and I did publish them actually in one of the papers, but I wasn't happy that they were helpful enough to change our practice in that moment. And I think it's very important for us to think about that moment. How do we actually recognize something in the moment so that I don't actually do that next step of cutting the bile duct, or do that next thing that will lead to a patient outcome? How do I become present enough in the moment and understand the things that are pressuring me and the things that I am doing in the field as a whole person, and the trainees around me and the people around me? How do I understand that in the moment? And I came across a paper by Shifra Ginsburg, who is a physician actually here in Toronto at another academic institution. Shifra she was studying professional behaviors, and she divided these behaviors into avowed, unavowed, and disavowed. And as I read the paper, I started understanding that this might help us, some surgeons in the moment, understand some of the pressures that we actually feel that go towards impacting our decisions. And I'll just share with you an example from each. So the avowed is if we are in the moment and we're thinking about the patient's best interest. I might be doing a surgery and thinking, you know, the best interest of the patient is for me not to proceed. You know, a Whipple procedure, a pancreatic procedure, I don't think I can cure this patient. The best thing for this patient is to close up and put the patient on chemotherapy and talk to them about that because I can't proceed. Another example is I gave the patient a stoma. He didn't want one, but I really felt it was the best thing to do, the safest thing to do for him. So that's when we can go out and talk to the patient's family. The avowed things are where we can actually go out and talk to the patient or the family and say, this is why I did this. It's also the framing we often use when we're presenting a case in morbidity and mortality rounds or QA rounds. You know, we try to frame this through the avowed framework. But there are other things that influence our decisions. And one of the other things is the unavowed. And these are the things that we can talk to each other about. We're unlikely to share with the patient or the family. So we're unlikely to talk. These are the things like academic pressures, time pressures, like Shri just talked about today, for me being on call. So if something's happening right now and I'm in my office trying to give an academic, talk, a lot of us would understand that. And if I said something happened and I was here giving a talk, you'd see it, maybe differently than if I told the patient's family that or the patient that. And so these are the things we can share with each other. So whether it's, academic pressures, some people may put in family pressures in here, like my son's birthday today, or, different things you can put into the unavowed and share them with each other, but not let necessarily the patient. And one of the things is the clock. It came up repeatedly. I think the pressure of the clock is distracting and you hurry things along. We know that it's the wrong thing to operate by the clock, but we're put in a position where we're in some ways forced to do that. And as a medical director, I've often thought about this, what are we doing as a system that's pressuring surgeons to hurry up and to continue to have to get the next patient, on the table. And then the final category here was the disavowed. And these are the things that maybe we probably couldn't even talk to each other about. Now, we're in a fee-for-service system right now. That's the system that I'm working in. If I have an empty OR list, if I have a day coming up that I don't have a patient in, I sense it. It's not like I'm a bad person, but I do have a sense that I should put a patient in, like I'd love to find a patient to put in there, or if I'm actually in a Whipple procedure and I'm thinking, the best thing for this patient is to close, there is a sense of a loss of income in that patient. Now you might say you're a bad person, but I don't believe that I'm a bad person to have those thoughts. And I think that's where we need to have these conversations, that let's not shame, let's not talk about it in those ways, but let's put it on the table and understand how we are influenced in order for me to actually in that moment pause and say, this is a disavowed thought, this is the avowed thought, what are they? Like differentiate them and then carry forward with as much as you can the avowed thought. This is another disavowed principle is our ego. There are ones like, well, do I really need this help? Do I want to seem like a loser? Am I going to call someone? And again, coming back to the moment, how do we use this framework to understand how we actually make decisions in that moment and how judgment can be influenced by more than just cognitive? The second study I wanted to share was the idea that I remember all of my deaths. A lot of surgeons, when they talk about error, share this, that they remember the details explicitly about their deaths. And they can often share the details of something that happened 20 years ago. And many of them shared stories that they hadn't actually, or details of the stories that they hadn't shared before. Because I don't think, again, we're not given the ability to do that. And so Shelley Liu, who was a student, actually did this study with me several years ago. And the first thing I was wanting to figure out is, am I unique in this? Am I cut out to do this because of the reactions that I'm having? Because we don't share them, I don't know how many other people are having the similar reactions. This kind of study qualitatively can actually answer these kind of questions. What are the reactions surgeons have to their error? And then fortunately, I found through this study that I'm not unique, that many of us actually share similar reactions. Second question I ask is it because I'm female? So as a female surgeon, we often are feeling, I think, that maybe we have these feelings because we're female and we feel more. or we're too soft, or we're too, we communicate too much and I've shared too much. And one thing I recognized when I asked females in the study, do you think this is because you're female? Many of them said, absolutely there is. And often they would say, they'd answer the question before the question even came out of my mouth. Absolutely, there is no question in my mind. But then when I would talk to the males in the study, they would say before I even came into the room, who sent you to me? Did you hear that I'm an outlier? So often what's happening, I think, is that we attribute, because we internalize these things and because we actually experiencing them individually without talking or sharing them, we attribute different things to our reactions. But we're having the same reactions. We're just saying, okay, it's because I'm female or it's because I'm an outlier, but let's talk about these reactions. We often look at people and we say, he's different, she's different, they're made of steel, or they're a sociopath, they don't have feelings, they have reactions and don't talk about it. I can only speak on the outside, but they appear to have stuff slide off of them. And so we actually made a point to go into every division and every surgeon who actually had this kind of reputation to find out if they did. And I can tell you that none of them did. So all of them were able to, some it took a little bit harder to get it out of them, but all of them actually were able to share their experiences. And in the end, they were all the same experiences. So what is this experience? Just quickly, there's 4 phases. One is the kick, there's tachycardia, and there's unease, anxiety. This is the first phase when you hear of something. You hear your patient's gone back to ICU or dropped dead, or blood's coming out of the drain. You get this kind of tachycardia and the gut drop, and many different physiological responses. But also with this phase is this imposter syndrome. I'm not entitled to walk around with my lab coat and my scrubs and be a surgeon or a scientist or whatever. You just feel personally devalued. A sense of shame. You kind of want to hide, run away and hide in the corner and be alone. I almost crashed into 4 parked cars before I got out of the parking garage that day. I was so distraught. Like, I'm not a guy that cries, but. So you're dealing with the emotional turmoil and that morbid feeling of you've done something bad, and it generally incapacitates you. So surgeons talked about, not being able to focus on any other thing that day, not being able to, do that research paper that they were wanting to do, or have that nice weekend away because they're now incapacitated. The second phase was the fall, and this is where we start looking at the question here is really, was this my fault? Did I goof something? Did I miss something? Is it a technical problem? So I relive the operation and I go through the critical parts of the operation. And unfortunately, this is often where we blame too. I think if we actually were to be honest, we're looking for someone to take it, right? To take the fall, because it hurts, it's painful to fall. And so, we're looking for it. This is the time when we might think, but where maybe we make things more clinical and not actually dig deep and think about what it is that we could have done. But then comes the recovery where we're able to, hopefully comes a recovery where we're able to think about it and say, marked by this question, what can I do better? Or what can I learn from this? I'm going to learn from this. I'm not going to dismiss it and say, well, it's the patient's fault or the nurse's fault. Sort of learn from it, whatever the problem was, and move on. And this is a time where we feel, okay, the pall has lifted. I can now start talking about the case. I can maybe even more deeply reflect on my role in the case. And you can get up or not. If you don't get up, that's slow suicide or termination of what you do for a living. And then the final phase is the impact. And this is over years and many years, surgeons shared how this affected them and in their practice. And many people have personally come up to me afterwards and talked about how they've been impacted by our profession and what we do. I think that each mistake I make, or each complication I have, or each patient I bury, I think has taken a little wee piece out of me. It's that kind of obsessiveness on my side that's aging me at an incredible rate, affects my tolerance for taking chances. I get to a point where there are fewer and fewer cases that I get really excited about. Like, I see the very negative side of it, or the negative is starting to outweigh the positive. The truth is, you're also worried about yourself. I think really you're worried about your reputation, how people are going to think of you, the finger pointing, everyone in the community is going to know. And I think as we think about reputation, we often think about it as, how bad we are that we actually worry about our reputation. But the fact is, it's the culture that we live in that makes us worry about our reputation. So it's not, it's like a, you know, an individual issue or a system issue. It's the system issue. It's the culture that actually teaches us this. And I just want to share with you a couple of social theories, not cognitive theories, but social theories that start to help us understand why we think this way, and maybe think about how we might change our culture to get past it so we become healthier, not only for our patients, but for ourselves. This idea that we have this huge expectation on us. And in reality, we're often feeling fairly isolated and alone in our profession. Not all the time, but there are many times when I think many of us feel that. And so what is that about? And so a few social theories, I know I'm going to be running out of time, but a few social theories. So this idea of a constructed identity. We come into surgery and we become a surgeon, and you become a cardiothoracic surgeon. You become a hepatobiliary surgeon. You become a plastic surgeon, or you become a psychiatrist, right? Or a gynecologist. They all have different identities. If I had my second choice after medicine was music, if I didn't get into medicine and I got into music, I suspect my identity right now would be a lot different than it was that I got into surgery. So we construct identities. They don't always just, we're not born with them. We're born with traits, but we construct the identities. And so what's a surgeon identity? Someone who's knowledgeable, confident, decisive, and walks with their head held high. They have that like strut, that like surgeon's walk. You're not supposed to be afraid. You're supposed to be in control. You're supposed to know everything. You're supposed to be able to do it. I'm going to just skip that theory, but the very important theory is this idea of performativity. This idea that we have a front stage. So Goffman uses the idea of acting. So you have a front stage of who you want people to see and you acting for them, and then a backstage of how you actually feel. And I think this is a very important one as we actually start to understand how we negotiate that from moment to moment. And it's not that we can't do it. It's not like we were always doing that. And that's actually, even if you're looking at home alone and looking in the mirror, you're doing that. Or as you walk in, you're becoming the wife or the mother, you're doing that. So it's just understanding how we do it and maybe make the explicit decisions and train people how to do this performativity. How do you want to perform in the operating room? To Michael's point, what kind of surgeon or what tone are you setting? You know, make this deliberate, not kind of behind the scenes. This was a colorectal surgeon. It was a horrible case and I couldn't identify the rectum. I couldn't even identify the sigmoid. So I'm operating with the senior resident and thinking to myself, I'm a colorectal staff and I can't even identify the rectum. I'm not saying it to anyone else in the operating room. I'm like, God, I'm like giving the perception that I can tell what's going on here. I think there must have been a lot of time spent doing nothing. During that time in the OR, there's probably very minimal going on in terms of actual operative patient care. It was like taking care of myself. This idea of socialization is the last theory, that we become the last generation. So we teach people through what we value and our behaviors, what we expect of them. And so this other idea is, how do we bring this into the cognitive capacity model? There is a whole bunch of effort that we actually take to try to measure up. You'll see it in your trainees when they're performing on ward rounds for you. You know, and you're making them perform for you because we actually have what we value and we live it, even though we don't even know we live it in the hidden curriculum. So instead of actually just focusing on our patients and focusing on patient care, we have all this other noise going on. And this is just two fellows talking to themselves. Two fellows doing a kidney transplant, and this is the first year fellow that talked to me about this. And then the staff showed up just outside the operating room to see how things were going on. And I can see the fellow getting completely nervous and then completely changing and telling me, go faster, come on, you have to grab it. When beforehand we were just going at a normal sort of slow pace. He got nervous to the point that we ended up putting the kidney in upside down. So we had to take all the stitches out and put it back in again. And so I think what that means to me is, how do we actually create an identity that's more aligned with a mindful surgeon, not a fearless surgeon, but not a decisive, confident surgeon. But how do we actually create that more mindful surgeon? And I think we have the tools now to understand how do we do that. It's making decisions about what we value. It's making decisions about how we train. it's incorporating a lot of this, like you're doing now, incorporating this training into the lives of the surgeons who are operating. And so I applaud you for that and taking on this as a seminar. Thank you.
Thank you very much, Carol. That was very insightful. I think we have got a question. We've got time for it. And if not, if you're staying till the end of the meeting and haven't been called away, we can take further questions. So the one question is, do patients' deaths ever become bearable?
You know what, I would say yes. But there's a proviso. I think there are a few people among us that they seem to take death or the mistakes or errors very, very, it's not personally, it's actually they feel what the patient feels. It's almost like they have a lot of the ability for empathy, and they actually get destroyed by things like that because it's almost like they're taking on their patient's pain. I do think that there is a phenomenon. I don't think it's the majority, but I think that happens. And I think, counseling and understanding that might actually be very helpful. Or maybe even aligning yourself with a certain specialty where you're not actually dealing with that. Maybe that's actually important. I don't know. But I do feel like myself, as I've understood these reactions and I've understood the role that reputation might play in it, and the idea that if you can be mindful and try your best, you're not going to be perfect, but you'll always try to, be as best you can. And then if you allow yourself to not be perfect and have, complications, but think about them and learn from them, I think that's the most we can expect from each other. So I think yes, you can get over a patient's death. But think about the meaning of it. Like, what did you learn from it, and what will you take away from it as a surgeon and as a person? But it's a complicated question to answer in 30 seconds. But yes, I think you can change the reactions that you're having.
We've also got a comment from one of our nursing colleagues who says that the surgeon is the one who's always in the spotlight. However, as a non-medical surgical practitioner, we feel the same pressure of time and social pressure to deliver and teach. No one comes to ask how they felt after something has gone wrong. Okay, I think we should move on in the interest of time to our next talk. Thank you very much, Carol.
Thank you.
So for the next talk, we've got Professor Peter Brennan, who's going to talk to us on human factors in patient safety and surgeon safety. Professor Brennan is a consultant oral and maxillofacial surgeon who works in Portsmouth. He is committed to education. He has over 600 publications with more than 75 on human factors and patient safety. His extensive human factor work and unique collaborations with airline pilots, the UK National Air Traffic Services, and also the Red Arrows Royal Air Force team have resulted in many changes in practice, better team working, patient safety across medical specialties, as well as changes in the MRCS delivery internationally. So without further ado, and taking time away from Professor Brennan, I shall invite him to give us some insight into this topic.
Oh, thank you. Thank you very much indeed, and I very much appreciate the opportunity. And just to pick up on what was just said earlier, I mean, we all make mistakes, and I think going back as far as Latin times, I think it was Cicero in 100 BC said that all of us make mistakes, but only a fool doesn't learn from that mistake. So it's equally applicable to surgery, of course. So thanks very much. In the next 25 minutes or so, I can literally only scratch the surface of human factors. But I think the thing that's most important to say is that we all make mistakes. human factors application, in a sense, is just common sense application at work. You know, we go to work and we leave common sense at the front door on so many occasions. So let me walk you through a very simplified view of what human factors, as I see it, and as I say, it's literally only going to scratch the surface. Now, if I can just try and get this slide to go forwards. Yeah, so as you very kindly said, I'm an NHS consultant in oral and maxillofacial surgery. I've completed a PhD on human factors application in healthcare, and written quite a lot on it with lots of the team, really. So with trainees, with nurses, with other specialties. And again, my common theme going through this really is common sense application. It's important that we all make mistakes, and we all recognize that. So we make about 5 to 7 mistakes every single day, and it might be something simple like forgetting to bring your lunch with you when you come to work, forgetting to put the washing on because someone telephones you. But we all make mistakes, and if you translate that into the hospital setting, 1 in 20 hospital admissions has some form of error. Now, it might be something minor like forgetting to do a discharge summary, something like that. But of those 1 in 20, another 1 in 20, so that's 1 in 400 admissions has some serious medical error. 1 in 400. And this comes from a number of studies, but the one that I use is this huge meta-analysis of 337,000 patients published in the BMJ 2 years ago by Panagiotti et al. And the commonest errors occur in the operating theatre, so particularly relevant for us, but also in intensive care, and errors with medication and prescribing errors. But operating theatre error is one of the commonest causes of error. So really understanding how it happens and what we can do to stop it is key to improving patient safety. I'm sure you'll be familiar with the so-called Swiss cheese model of error, coined in 1995 by James Reason. So I think it's a Swiss cheese that's got holes in it. And if you just imagine that being on a skewer, and those slices of cheese are just slowly rotating, every now and again, one of those holes is going to line up all the way along to produce an error. Error actually starts in the organizations where we work. And so, for example, a common one is an already busy operating list, and a manager will try and put an extra patient onto that list because of pressures or whatever. And so you then feel pressured. You might want to operate a little bit faster. You're increasing your risk of making error because that started in the organization. For me, and part of my PhD is really concentrating on one of those layers, the so-called preconditions. So if you can block that hole in the Swiss cheese, you can almost certainly prevent that error, such as a wrong site operation, or a major error that could be preventable from occurring. So the preconditions for me are the key really to human factors application into surgery. And I break those down for the purpose of this talk really into individual factors. In other words, looking after ourselves and optimizing our own performance, and those of the team, because we all work as part of the team. It's really important to have great team working to ensure that we work together really well, improve patient safety and morale, of course, as well. So those are the 2 factors I'm going to concentrate on. And then finally, a little bit at the end about lowering hierarchy, which again is just so important. So I only want you to remember 2 things from my talk. And this is the first one. When you get on an aeroplane, they always say, put your own mask on before helping others in the event of a cabin depressurization. And that for me is the key to understanding human factors. It's looking after yourself and optimizing your own performance before you look after patients. Now that sounds perverse because we go to work to look after patients, of course we do. But if we're not optimized in our own style, in our own manner, we're not going to provide the best possible care we can for our patients. So what do I mean by looking after ourselves? Well, these are some of the things I want to talk about in the limited time available. This is one of my good friends. He's an enormous bodybuilder there, as you can see. He tells me he never takes steroids, but I'm not going to argue with him. I mean, look at the size of him. But he's a nutrition expert, and we've published several papers together about safe nutrition and improving performance through nutrition. And basically, what he says is that we should be eating every few hours, even if it's something small. We should be eating regularly, a little bit like putting firewood onto a fire. You have to keep that fire burning. That's our metabolism. So how many of us go to work in the morning not having eaten breakfast? A lot of us do that. Now, if you do that, you are not optimized metabolically speaking. You're burning ketones, so your brain is actually metabolizing and things, and obviously that's being changed to glucose, but it's not ideal, you know. And so if you look at performance of school children, there's an enormous study from the States of 100,000 school children comparing those that had breakfast and those that didn't. Surprise, surprise, the children that had breakfast, they performed so much better at exams, class assessments, sports, and everything else. It's obvious, really. But how many times do we have a huge operating list of 8-9 hours and we just carry on and we don't take lunch? You know, we're going to become hypoglycemic. We think we're fine because we've done it for years and that's just the way we are, but we are slowly deteriorating in terms of performance. And it's not just eating, it's fluid balance as well. So this is a urine color code chart. And so we should be drinking 1 to 2 liters of water every single day. And how many of you go home at the end of the day with a headache? And the answer is a lot of us do that. And one of the reasons is because we probably haven't drunk enough during the daytime. And of course, particularly in the summer, the hot climate, wearing PPE, we perspire, we lose water. Now, if you lose 1 to 2 kilograms of your body weight in water through perspiration, your cognitive function falls by 20%. So this happens again very, very slowly. So you don't even know it's happening, but your cognitive function, you know, the way you process information, that is actually falling slowly. But because it happens slowly, you don't even know it's happening. You need to drink regularly. It's just so important. So this is a paper we published in the BMJ about 2 years ago. It's had 250,000 downloads, but it's just common sense. You know, we need to eat and we need to drink regularly. So I would strongly recommend, you know, taking those breaks, having something to eat, having something to drink. And if you don't have breakfast, please just try that. Please have a cereal bar or something and just see if it makes you feel better and maybe your operating performance as well. Now, obviously, we bring our whole selves to work. We bring emotional elements to work, you know, how we feel and things. If you're angry, you are 30 times more likely to make an error. And many of us will have been in theatre with others, and suddenly a surgeon, someone just loses the plot and just shouts at the team. I've done it in the past. You know, it's a stressful environment. There's something called a sentinel event, which if you reach that sentinel event and you go past it, you are so much more likely then to shout and to lose your temper and to become angry. And as I've said, you're 30 times more likely to make a mistake. But also, it's more than that. If you shout at staff, it's just not acceptable. You know, 80% of people that shout subsequently regret what they've done. But how does that affect the rest of the team? People feel vulnerable, people feel upset, you know, performance suffers as a result. So I can't really talk about anger management today, we don't have time, but just to make you aware that, you know, that anger is a major contributor to error. And finally, just in terms of individual performance, tiredness and fatigue. So fatigue is a cumulative event. So which, you know, if we're constantly tired over days and weeks, we will become fatigued. Obviously, particularly important during the pandemic and things, all of us working way in excess of hours and not having holidays. But if you're awake for 18 hours, non-stop, your cognitive function is the same as being twice over the UK alcohol limit. Again, it happens slowly. You don't even know you're aware of it. But if you've been awake for 18 hours and you're trying to perform or you're trying to operate, you are effectively, and there's lots of published studies on this, you are effectively operating the same as being twice over the UK alcohol limit. So how long is safe to operate? And I would just say to you, would you drive, say, from London to Edinburgh or from Edinburgh to London, 7-8 hours? Would you do that without taking a break? And the answer is probably you wouldn't. You'd stop halfway and you'd take a break. And yet we can operate for 8 hours non-stop. I mean, that doesn't quite seem right, does it? Again, that's common sense application, and us maybe sometimes leaving common sense, and we think we can operate for 8 hours because we've always done it. The fact is, if you look at performance and you look at all the physiology and all the work that's been done, you cannot do that to the same performance for those 8 hours non-stop. Please, please, please take a break. This is an unfortunate junior doctor who fell asleep at the wheel after having done a series of nights and unfortunately died. And again, so it's a number of errors started in the organization. She wasn't given anywhere to take half an hour sleep prior to driving home. So error is usually multifactorial, but occasionally with a catastrophic, tragic outcome, as you can see here. So across the side of the roads, you'll see these signs: tiredness can kill, take a break. And that's because tiredness really can kill, and it does affect performance. So, please, please, please adhere to that. And if you do work for 7-8 hours non-stop, please think about changing your practice and just seeing if that makes a difference, because you might be able to do it, but how does the rest of your team feel? They will go with you on that journey because they maybe feel unable to speak up, or the trainee may want to break, but they feel unable to do so because of hierarchy, and I'll talk about that a little bit later. So there's only the two things I wanted you to remember. One was put your own mask on before helping others. The second one is halt. So what does halt mean? Well, it means stop. So if you're hungry, angry, late or lonely or tired, unless there's something acute, so there's a hole in the aorta and the patient's bleeding out. Now, of course, if you're hungry and you're angry about that, you can't walk away from that situation. You can't. But most of the time, you can. If the patient's safe, you can stop, you can step back with you and the team, even walk away, grab a cup of tea or coffee, whatever, and come back and carry on. And we've published ourselves on this, that even by taking a 10 or 15-minute break, you actually catch that time up, because you then improve your own performance, and of course that of the team as well. So let's move on and just spend a little bit of time talking about team performance then. And so I just want to talk about communication, briefing, situation awareness. So when your life depends on that briefing, as airline pilots do, of course, I can never compare aviation and medicine. Please don't ever compare the two. I take lessons from human factors application from aviation and things and apply them into theatre. But what do? They introduce themselves and they will say to each other, and I think we should, anyone can speak up. So if you have any concerns at all, please just stop me. Please just speak up. I'm not going to bite your head off. I'm going to stop and listen to what you've got to say. That's really important. And engage with that checklist as if your life really does depend on it, rather than just saying, yup, paying lip service to it. The number of never events is actually going up at the moment, rather than down. So there's about 650 never events in 2018-19 compared to 350 4 years earlier. Now that may be increased reporting, of course, but the number of never events are going up. And one of the reasons is people don't engage with the checklist as if their life depends on it. Identify the what if scenario. So thinking ahead, I'm going to talk about that in a second. And situation awareness, again, I'm going to talk about that. So thinking ahead, being aware of what's going on around you, that's just so important. Minimizing distraction is important. Again, I'll mention that towards the end. And finally, taking those breaks, and actually say that at the brief, we're going to have some breaks during this long operating list. So when we talk to people, 80% of communication is non-verbal, but when we do talk with the rest of the team, we want to talk in an open manner. We don't want to use pronouns, so we don't want to say I'm going to give it as a drug. You want to name what the drug is, so it's absolutely clear that there's no ambiguity. And you want to ask open questions to the team, such like, what do you think we should do here, rather than I'm going to do this, is that okay? And if you ask that open question, you're actually empowering the team. Everyone's then on board with you and actually thinking about those situations. So just what you say and what you think you're saying, is that what the receiver actually understands? And so for safety critical situations, we would suggest repeating back and actually asking the receiver, what do you think I said? Or please, can you just clarify what you think I mean? They don't have to repeat back word for word. That's a little bit anal, but but certainly the repeat back makes absolutely sure that what your instructions are really clear and understood. And just looking, say, at other industries. So when you collect your bags off of the plane, you'll see there, have you collected your luggage? And you then go through the door and it will say no return. Have you collected your luggage? So it's absolutely clear that you've got your luggage as you walk out the airport. Now compare that to medicine. These are two very, very similar. So one's adrenaline, one's amiodarone, and they're both in almost identical packages. So it would be very easy to actually inject the wrong agent, the wrong drug, and that happens. And that is an organizational issue, of course, that the errors actually started at that organizational level. So situational awareness. Again, I've only got a few seconds to talk about this, but effectively, it's what's happening around us here and now, and what might happen in the future. And I've actually looked, and as you very kindly mentioned at the start, I've worked with the Red Arrows. Now they have got the most amazing situational awareness, and if you look at his helmet, you can actually see the arrows there in front of him. This was a selfie taken on display. Subsequently, the RAF has said we're not allowed to use, or they're not allowed to take selfies, but I'm allowed to use this picture, and I've published this picture with them. But they really understand situational awareness, what's going on around them. And so how can we apply that then into the operating theatre? So if you're oblivious as to what's going on around you, you've got no situational awareness whatsoever. You start to build situational awareness. You kind of notice what's going on around you, and then as you get more advanced, you kind of you understand what's going on. And as I mentioned at the briefing, if you start thinking ahead, you've got the best situational awareness, because you're actually thinking for those possible errors or those possible problems before they even happen. So if you do think ahead, you're actively going to avoid an error. If you understand a little bit more, then if an error happens, then you can trap it and you can stop it progressing. And if you're oblivious, you're not going to know what's going on. An error is going to happen, and then you're into mitigating consequences of error. So it's building that situational awareness both for you and for the team. So one example is this: we always buy milk for each other. So I want to know when the milk's halfway empty, so that I can go out and get the next. Bottle, rather than right at the bottom, as you can see here. That's not good situational awareness. So it's right at the bottom, and then I go to the shop, and the shop's closed. So that's just a practical way of showing you good situational awareness. So what about multitasking? All of us multitask all the time. And the fact is, you think you can do it, but you cannot do it to the same standard. It's just impossible. And we've published on this ourselves, and as have lots of others. Multitasking impairs hearing, and impairs our manual dexterity. So we're operating, someone comes in, wants to try and interrupt us. Oh, can I ask your advice about this patient on the ward? You then carry on operating. You're then thinking about that conversation as well as the operating. You are so much more likely to make a mistake doing that. So just be aware that it's almost impossible to multitask. And so particularly for cardiothoracic surgery, this is a study that we've done recently, looking at distraction in the cardiac catheter lab. So again, high risk area. And we used a NASA task load assessment tool, so a freely available tool that assesses workload effectively. This is published in Open Hearts. It's an open access, very high impact journal. And effectively 194 procedures. In over half of the procedures, the cardiologist was distracted through interruption, the telephone ringing, someone asking him or her something. distraction. And in 10%, they were serious distractions that could, fortunately, there were no error, but could have caused a serious error. So please just think about distraction. Noise, of course, is a great distractor. And the more you're concentrating, if you're doing delicate surgery, noise becomes accentuated, and it's so much more difficult then to concentrate when there's noise. So again, from aviation, we use something called sterile cockpit, and that's effectively anything below 10,000 feet. So on the takeoff and on the landing phases, they only talk about essential procedure. So they're not going to be talking where they're going out for dinner, or they're going to have the cabin crew coming in and bring them a cup of tea. They're just talking essential procedural type things. And so at the team brief, we will say, and I would recommend this, saying at that team brief, there may be times when you need to concentrate on things. Please, at that point, I just want minimum noise and essential conversation. And we'd recommend turning the music down or off. Music's an interesting one. Actually, people say, oh, I have to have music playing, but the music that you might like might not be what everyone else in the rest of the team likes. So again, if you're going to use music, please consider using a playlist, or alternatively get your trainee to bring in a CD or whatever, and then the nurse and someone else, so that everyone gets a go at the music rather than the consultant all the time. So finally, lowering hierarchy. So when we put on a name badge and it has has consultant or has specialty registrar, that instantly creates a hierarchy with those people more junior to you. Whether you like it or not, it instantly creates a hierarchy. So for example, a foundation doctor will automatically have some hierarchy with a medical student, for example. And it's how we're actually perceived that actually makes the difference. So would you, if you were the person on the right of that photo, would you feel able to challenge the person on the left there that was actually breathing down, just about to attack you? And the answer is you wouldn't. You would feel smaller. You would feel unable to challenge that person if they were going to make a mistake. So again, from aviation, it's a very shallow gradient on the flight deck. So the most junior first officer can speak up and challenge the most senior captain without fear whatsoever. He or she can call and say, look, I'm not happy with this, or, can we do this? And the captain has to listen and actively intervene or whatever for whatever that first officer has said. And we need to bring that into medicine. So easy to do it. You as the more senior people in the team have to actively lower that gradient, and you do that at the team brief, and you do that by saying, please speak up, please interrupt me, what have you. It's the way we behave that makes all the difference. This was pre-COVID, of course, social distancing not there at the stage, but there's a number of ways. So if you put your name on your hat, as you can see, Matt's one of our anaesthetists. He's got Matt anaesthetist. Now that does not lower hierarchy whatsoever, and there's no published data on it either. All it does is it tells you that he's Matt and he's an anaesthetist, so it might be good for communication. But he has to actively lower the hierarchy for the rest of the team, and the only reason that the only way he can do that is to actively do it himself. He could be the most objectionable, hard to approach individual, and just because he has Matt and anaesthetist on his hat isn't going to make him approachable. You have to actively go about doing that. So again, we published this in the BMJ, another article in the BMJ about 2 years ago. Improving patient safety, we need to empower junior doctors to speak up. And I wanted to actually publish that, saying we need to empower the team to speak up, but the BMJ wanted us to use junior doctors because it's a medical journal. But this applies to the whole team. So anyone in the team should be able to speak up, from a healthcare support worker to the most senior consultant. Everyone for me is valued the same. We're equal value in that team. And that brings me to respect. So, respect is actually earned. There is a certain amount of respect for being a consultant, for being a specialty registrar, for being a matron. There's a certain amount of respect automatically, but actually respect is earned, in fact. So you will get far more respect from the way you behave with the team, the way you empower the team, the way you value the team, and they will be looking out for you, and that improves situational awareness and all the other things I mentioned. and then they will respect you. And it's like a respect circle. It goes round and round. Respect is hard to earn and very, very easy to lose. So if you suddenly shout at someone after having worked with them for years, and you're rude or you belittle them, you can lose respect in a flash. Literally, it can go. So, you know, if you think you're about to shout or anything like that, please just stand back from that situation and think before acting. Remember that halt thing. So that really brings me to the end of a really kind of whistle-stop tour of human factors. It's, you know, we're all fallible, we all make mistakes, and actually recognizing that every single one of us makes mistakes every single day. And once we recognize that, that's the first step to improving our practice and how to optimize our own performance and that of the team. And the way we do that is, as I say, taking those regular breaks, eating and drinking regularly. You know, I've got a glass of water here. And if in doubt, you know, stand back from the situation, walk away if it's safe to do so, and lower those gradients. You know, the days are gone from the consultant being you know, stuck on the pedestal, you know, the Sir Lancelot Spratt type characters that you couldn't even speak to. Those days have gone. The way we need to improve patient safety is to lower the gradients and things. Yes, there still has to be a gradient, of course there does, because the consultant is ultimately responsible, but it needs to be so shallow that anyone can speak up without fear. I know it's the middle of summer, or coming up to the middle of summer, but we published an article in the Christmas BMJ last year about Father Christmas and how he does human factors. And it's a 900-word, 1,000-word, very short article, quite amusing, about how he empowers the reindeers, how he's got situational awareness, and even Santa can lose it. He falls off of roofs and things, and, you know, the effects of alcohol and being up for 24 hours. So please have a read of that if you'd like an amusing summary of HF application and things. It applies to us all, not just to Father Christmas. So again, I'd just like to thank you so much for the opportunity. I'm sorry it's just a whistle-stop tour. We could spend all afternoon talking about each of the individual factors in SA, but you know, just really to give you an overview of the factors that affect our performance and those of the team. Thank you so much again for the opportunity.
Thank you very much, Peter. That was a wonderful whistle-stop tour of human factors. I mean, there are a few things which you said resonated. One of the delegates asked the first speaker, Mike Lewis, where is the X factor in surgery and how people train? You've just talked about driving 4 hours without interruption. And I used to work for a surgeon who will kick the team out for a break, saying, it's 4 hours, go stretch your leg, have a cup of tea, then come back because you're no use to me continuing on. And once you were back and it was safe, he will do the same thing.
Yep.
And the situational awareness is so important in all of these things. You've alluded to the first aspect, Richard, the lens has gone, your blood. The briefing and the importance of it. And the colleges have just announced that we're going to use team briefing for training as well, as much as telling the team, look, this is the bit we're going to be focusing on with silence and focus. We're also going to try doing that with training so that if your trainee is doing a part of the operation, it is not impacting. There's a question about music. Is it a distraction or is it?
Yeah, so the music's a really good one. And as I say, we've actually published on this ourselves as well. And I think music is good, actually, to be honest. But, you know, like I've said, if you have a particular piece of music, you know, you might like Mozart's Tree and I hate it, for example. And so you have that every single week, and your trainees don't like that. So a playlist, I think, is a really good idea. And I think at the safety critical parts of surgery, you know, turning the music down to a very low level is really important. Some people say, oh, I turn it up because it helps me to concentrate. Well, again, have you ever asked the team, does that affect your performance as the team? And you ask them that and they say, oh, I've never asked the team. So, well, why don't you go and ask the team? And almost always they come back and say, yeah, Peter, you're absolutely right. I should have done. it distracting. So yes, by all means use music, but be careful with it, I think. Yeah.
So in the first session, we talked about the value of non-technical skills, human factors, running courses. And one of the delegates has asked, what are your thoughts on having these courses, particularly in teams in difficulty, when there are issues within the team? Would a human factors, non-technical skills course help?
So I think, I mean, for me, you know, there's some elements of human factors that are individual, as we've discussed. But I think, you know, the best way to get training of HF is actually for teams that we work together, rather than just one person coming here and whatever, and everyone then just comes together. So it's a team teaching, and that's certainly how we do it down on the South Coast. Teams in difficulty, you know, that can sometimes be difficult to dissect out what the problem is, and whether there's one problem, or whether it's one individual, whether it's multiple factors and things. But I mean, certainly there's leadership courses. There's all sorts of courses dealing with difficult you know, colleagues, difficult team working and things. But I think just going back to the basic principles, being open and transparent, empowering everyone, you know, sitting down in a room, and that can be very difficult, you know, if there's issues between colleagues, but being open about it and saying, right, okay, leave the guns at the door, you know, let's go into this room, shut the door, and try and sort things out. And again, it's very difficult to answer, isn't it, in 30 seconds.
Thanks, Peter. It's fantastic. We still have Professor Moulton with us. There was a very pertinent question. How would you educate or alter the system such that trainees feel able to action disavowed behaviors, example, calling for help when it is appropriate, without being labeled needy? Yeah,
so you know, I mean, I
was going to ask Professor Moulton to answer that, because that was part of.
Yeah, brilliant.
I'll just come back.
I'd love to hear Peter's view, but I think it's difficult. I think, again, a lot of this teaching, I think, has to come from modeling, because I think if you tell people to do something, they're very influenced by what the other theory that I talked about, socialization. They understand what's valued. They want to be that surgeon that's valued, and so they will do what they think that needs to be done. So if they don't think calling for help is valued, and they've seen that through others, then they will not likely call for help, or they'll struggle with calling for help. Once you start modeling it, and even maybe promoting it, and actually, like, you know, choosing that as something you value, making that explicit, then it becomes easier. And that's from an individual perspective or a cultural perspective. There's also a system perspective. Maybe we need, like in the first 6 months of somebody's career, as they finish their fellowship and go into staff or attending, then that's where you need to surround them with the system where they don't get a choice to have to call, right? You actually have a surgeon there, because you understand the vulnerabilities at that point to both the surgeon and the patient. And so the system comes around them and provides a safety net, and has a surgeon that pops in, or a surgeon that's kind of continually making themselves available. It's a different system. It requires us to rethink how we remunerate that, or how we value that. But I think you can think of things as individual solutions, cultural, you know, solutions, and system solutions.
Thank you, Peter. Thank you, Carol. And we've just had Professor Labaris joining us. We will listen to your advice. We can't keep our delegates and ourselves glued onto a screen indefinitely. So we'll take a short 10-minute break, and we'll reconvene 3:45. Welcome back. So we then move on to the next phase of our program. So we have with us Professor Carter Labaris from the University of California, San Francisco, who is an upper GI surgeon who graduated from the University of Minnesota, and subsequently has even come across the pond to spend some time in the Strasbourg University in France. She's a director of UCSF Center for Mindfulness in Surgery, and has 20 years of experience of mindfulness, meditation, And her long-standing research interests are stress, cognition, and resilience. When we constantly keep talking about surgeon burnout and stress, especially with the younger generation of trainee surgeons coming in, we felt it would be very, very pertinent to have her here to share her experience. Thank you for joining us, Carter. Over to you.
Hi, let me screen share here. Can you see this okay? Can you give me a thumbs up if you can see my slides? Great, okay. Hello, everyone. I'm Carter Liberis. Since I've already been introduced, I'll save time on that, but I would just like to say how honored I am to be part of this masterclass today. I wish I was there in person. So I'll be talking today about enhanced stress resilience training and how this can be accomplished through mindfulness, which has been the focus of my research for the last 6 years. Oh, pardon. Okay, so just a quick overview. I'll speak very, very briefly about burnout, specifically how this differs from well-being. Some conversation about stress and how this impacts cognition, and then I'll share with you the details, data, and some of the dissemination we've been doing around the Mindful Surgeon project. And then I'll finish with some of our most recent work on moving beyond burnout and beginning to look at what it takes to actually flourish in surgery as a new goal for the field. So really the instigator of so much of our interest in resilience and well-being in medicine has been the epidemic and increased awareness of burnout in medicine among physicians. So at this point in time, we're all familiar with burnout being this product of overwhelming and or chronic workplace stress, that it involves 3 domains: emotional exhaustion, depersonalization, and a diminished sense of personal accomplishment. And moreover, that about the last 15 years of research have demonstrated just myriad negative sequelae that have far-reaching impact on our personal and professional lives. And that this has been found to be true across medical specialties, cultures, and genders. But I think to date, many of us are beginning to just recognize that burnout is really just a surrogate for distress. And it's a distress that comes from, as I was just hearing at the end of Dr. Moulton's talk, a dis-synergy between individuals, systems, and culture. And I'll come back to that later. More recently, there's been economic impact put to burnout. And I think this is important because often it's difficult for us to frame human costs as being important, but economic costs are easier for people to agree upon as having quote unquote value. So this is a study that came out in 2019 from Tate Shanafelt's group, who've really been pioneers in studying burnout. And they used a rather complex mathematical model to estimate the annual cost of US physician burnout due predominantly to attrition and decreased productivity. And what they found was a $4.6 billion price tag to this. But of specific interest to us was also this 37% of this total being specifically derived from burnout in surgeons. And of that, 82% coming from attrition. And then particularly of interest to me as someone who works with trainees, more than 50% of that attrition was from surgeons under the age of 55 with a $900 million price tag. And so many of us, while recognizing that burnout is economically important and far-reaching, and that it's been the subject of intense focus for 15 years, we are confounded by the fact that we've not made much headway in decreasing burnout prevalence, MD suicide rates, nor really improving on physician satisfaction. And so I think a new wave of research that's been mounting is comprised of people asking if that is due to burnout actually being a rather oversimplified metric for what we're really talking about, which is well-being. And in fact, well-being is really a complex phenomenon. It's comprised of many components. I think that's well said here by the definition from the Center of Disease Control. Well-being is more than physical health and housing. Well-being refers to the quality of a person's relationships, their positive emotions, their sense of resilience, realization of their potential, and overall satisfaction with life. And this seems appropriate, in particular, when we talk about physicians and surgeons, because in fact, this complexity of what comprises well-being really mirrors the complexity of the work physicians do. So we solve difficult problems, but we tend to derive joy from that. We invest deeply in our patients and their outcomes, but this can be both gratifying and painful. And our work is often interwoven with our lives, not wholly separate from it. So it's not surprising that this means there is a certain amount of stress that is inherent to the work we do. So no matter what else changes in terms of systems or culture, there will be a certain amount of stress always associated with doctoring and surgery. And of equal importance to note is that stress is actually quite complex and heterogeneous. So specifically, not all stress is bad. And as characterized here in this cartoon, showing the Yerkes-Dodson inverted U-shaped curve, this describes the relationship between stress and performance, which has decades of empiric evidence supporting its validity, showing that while stress on the left side of this curve can be a good thing that pushes adaptation, mastery, and engagement, there is a peak performance zone, and this is really defined by each individual. But on the far side of this curve is where we see stress, which is typically chronic or overwhelming. Remember the definition of burnout. And in this part of the curve, stress really does result in the deterioration of cognition, physiology, and social interaction. And so one of our guiding questions was, how can we, if possible, teach people to shift how they interact with stress, how they experience stress, shift that on this curve. And so we know that a very powerful factor in determining how one reacts to stress, how one experiences stress, has to do with one's cognitive habits. And so there's quite a bit of literature across fields showing that habits such as perspective taking, positive self-talk, approach to teamwork, or a growth mindset all influence how a person moves through stressful experiences, either as challenges or, in the worst case scenario, as threats. And empiric work in this area is rooted in resilience science. And some of the critical theoretical underpinnings come from Barbara Friedrichsen, namely her broaden and build theory. And this posits that part of the reason why resilient individuals seem to perpetuate their own good fortune is because they cultivate positive emotions. And so this cultivation of positive emotions is believed to enable individuals to call on a wider than usual range of ideas and actions. This allows them to create behavioral flexibility. This builds personal resources like confidence, resilience, and social connections, and can even contribute to physical health. So this broadens what we are able to do cognitively and how we are able to interact with others behaviorally. And this has been described as the upward spiral of positive emotions, where we grow these resources within ourselves, it attracts others to us, we have positive experiences working in collaboration, and that in turn builds greater internal and then external resources. So we also know this isn't just a cool idea, it works. And so there are to date myriad studies showing that the cultivation of positive emotions, in particular through mindfulness meditation training, has done things that really other Western medical interventions have struggled to do. So for instance, substantial reductions in PTSD in military veterans, improved attention and cognition in Marines that are waiting to deploy to active combat. Of course, in the personal and publicly discussed practices of multiple peak performance athletes. And then near and dear to my heart is studies done by MIT showing improvements not only in pro-social behavior in public school children, which I think are called something different in the UK, but kids who go to schools that are generally under-resourced. But not only does this type of training enhance their prosociality, it also improves their math scores. So it shows that there's something both social and cognitive that this type of training influences. And it's worth noting that these types of studies are not coming out of the middle of nowhere. They are coming from some of the world's greatest institutions, MIT, Oxford, Harvard, Max Planck. So with these ideas in mind, we set out to develop what we were conceiving of as an internal curriculum, and specifically looking to define a trainable set of skills, which could be used, as I said, to influence where people land on the stress inverted U curve. And of course, one might ask, is there any footing as far as interesting as these ideas might be in the actual world of surgery? And so this harkens back to a national cross-sectional study we did with US-based surgical trainees back in 2016. And we just looked at burnout and all of the negative sequelae that we know come with it. But just really through serendipity, we also looked at inherent mindfulness. And this is really just a person's natural tendency towards the kinds of cognitive habits I described earlier. And what we found was that in those people who had a higher tendency towards mindfulness habits, they had a much reduced risk of burnout, stress, anxiety, depression, and suicide. And so this suggested something that we've long suspected, which is in fact that these types of skills, cognitive control, cultivation of specific useful cognitive habits, are actually skills that surgeons already possess. So this makes it even easier because what we're looking at is enhancing a set of skills that are already within us, but simply trying to help us hone those and allow us to be able to call on them in a more selective fashion. And so a little bit more on why we specifically chose to target stress comes down to the fact that stress, as opposed to individual stressors, has a universal central mechanism. And so while stress can be variable, that is stimulating or destructive, it's also variable in terms of what causes stress for different people by different things, even on different days. And yet, unlike targeting specific stressors, if we target the mechanism of stress, this allows us to train something that is useful across people, across career trajectories, and across situations. And so what this mechanism is founded on is this ingrained response that we have to stress, cultivated through evolution, where our senses perceive something, and then whether or not that thing we're perceiving is something moving in the shadows when we're alone late at night, or something like a loved one who we haven't seen in a long time approaching us, our body's reaction is the same. Our palms might become sweaty, our breathing might become more rapid, our vision might become sharper, and our hearing more acute. But then something happens between that physical reflex and what we do next. And this is the purview of the prefrontal cortex, which is often referred to as the master switch of the mind. And this top-down control of our bodies is what allows us to not simply run away from everything that causes us to feel these physical sensations. So I think a wonderful example of that is bleeding in the OR. So when we are medical students, we see uncontrolled bleeding in the OR and we push away from the table or feel nauseated. But we marvel at our role models who lean in and put a finger on it and get to work, usually not even sweating. And so this very natural human understandable response of reacting in fear to bleeding, we've overcome by training ourselves to do what is more effective, which is to act. So by targeting this central mechanism, our hope was that we would be able to equip surgeons with ways to mitigate stress in different environments, different contexts, and different stages of their careers. And so this is envisioning of this as a means of basic training, basic mind-body training that can be applied to pretty much everything. And specifically, in talking about mindfulness, what I am talking about is having an impact on this space where this star sits. So this is a space where one is going along in their normal life, an event happens, and then there is this variable time period where we have a reflex, and then we have the opportunity to respond. And so this is the domain of mindfulness training. So with all of these things in mind, in 2016, we created enhanced stress resilience training. And this is a codified curriculum. I'll talk a little bit later about the components that it's comprised of, but essentially it teaches 3 key cognitive habits: interoception, which is this mind-body awareness; emotional regulation, which is also often called arousal regulation. So that's learning where you are on the curve so that you can help shift yourself back to a place where you are in a high functioning zone rather than in an area of deterioration. And then metacognition, which is an understanding that these habits are under our control, which allows us to call on them more readily. And over the intervening years between the first inception of ESRT and now, we've been able to demonstrate in single institution randomized controlled trials several important things. So we've shown that ESRT is indeed feasible. Specifically, our residency program was able to deliver ESRT within the workday of our trainees, that the trainees were able to perform home practice daily, albeit with variable amounts of time. And they were also prone to incorporating these practices longitudinally into their personal and professional lives. We were also able to show efficacy. So ESRT has been shown to benefit mindfulness, increasing it, and that's maintained over time, as well as global executive function. And this is executive function measured by executive control battery that was developed for the NIH. We've also been able to demonstrate significant increases in activation in the dorsolateral prefrontal cortex, which is that master switch or control hub that I spoke about before, and in posterior parts of the brain whose roles in cognition are not quite as clear. And this was a statistically significant increase only seen in ESRT participants versus active controls during an emotional regulation task after they had received ESRT training. And then finally, perhaps most salient, is the beneficial effect of ESRT on both emotional exhaustion and depersonalization subdomains of burnout. And then most interesting to me is that we also just recently published on benefits that we saw in pro-inflammatory and beta-adrenergic, which is the fight or flight, transcriptome signaling pathways. And this was done using a social genomics panel developed by UCLA, Dr. Steve Cole, that's called CTRA, or the Conserved Transcriptional Response to Adversity. And what we saw in this was that our control subjects had about a 1.5-fold increase in this stress-related gene signaling pathway transcriptome, and that this was about 50% mitigated, a little bit more than that, in those who experienced ESRT. So to date now, we have this formalized curriculum bundle. There's 5 weekly 1-hour classes. There's a graded practice over the course of the class, and then several different materials that help support individual practice. And better than me describing it is one of our past participants just talking about how they use these skills.
So I use the mindfulness for a couple of different techniques throughout the day. I think one thing that's really helpful for me is mindful scrubbing in, meaning before we scrub into surgery, I like to take those 2 to 3 minutes to, instead of thinking about all the things that are waiting for me and the surgery that's coming in and everything else going on in life, I just practice mindfulness and completely focus myself so that when I go into the operating room, I'm completely calm, my heart rate's down, and I feel like that way I'm better centered going into the operating room. I think it's also very useful to transition between work and home. So before, I used to go home and kind of bring all the energy and the negativity and stress from the day home with me. Whereas if I practice mindfulness as I'm walking or driving home, I feel like that way I'm able to acknowledge the day, kind of let it go, and then go home without bringing it all home with me.
So besides these individual and personal benefits, like described by our resident there, We've also begun to see over this period of years a culture change. And this has largely been built from the bottom up. We've had increasingly larger numbers of residents train in ESRT each year. We tend to target interns because they don't yet know what it looks like to be a surgeon. And so they are more receptive to the idea that this is a natural and even necessary skill set for surgeons to obtain. And moreover, we see our participants beginning to talk about how the training that they receive benefits not just themselves, but also how they interact with others in the hospital system. So here's an example.
When I would leave the morning sessions and go back to work, I felt more energized. I felt more peaceful. I felt like I was able to deal with anything that came throughout my day. And it's all because of what we did during the course itself. Learning how to interact with others, whether it's nurses, your co-residents, your attendings, in a productive manner, realizing that people might want to fight you in a hospital and you don't have to engage in that. I think those are some of the lessons that I've taken and kept from mindfulness.
So in my last few minutes, I'll just talk about, here we have felt like we are beginning to learn how to shift the curve, that we're beginning to show our people how to do this. These are just a couple quotes. I won't fully read just in the interest of time, but they essentially say the same things that these two videos said before, that there are personal and interpersonal benefits that people are feeling. And then I think particularly of interest is that we see the effects of this not just in the petri dish of a classroom and a homogeneous group of interns, but we also saw effects of this when the first COVID-19 surge hit us in April of last year. And during that time, we assayed anxiety throughout our entire resident population. And our expectation was really that we would see what has been shown nationally, which is that anxiety is highest in young trainees and decreases over time. And then we just expected everyone's anxiety to be higher because of COVID. But actually, what we saw was the opposite of this, that anxiety was highest in our most senior residents and residents that were just a year behind them. And this was confounding until we realized that one major difference between all of the junior residents and the seniors is that all of the junior residents were part of waves of people who received ESRT. So ESRT has been offered voluntarily in this randomized trial format, but increasingly over time, more and more interns have decided to take it. And so there is a pretty substantial body of interns, or pardon me, residents now across the first 3 training levels and our 2 research levels who have received this. And so instead of looking at PGY level, we decided to look at whether or not people had received ESRT training. And what we found was that in those who had not received ESRT training, the incidence of clinically significant anxiety was greater than 20%. But in those who had, it was just over 3%. And this was a statistically significant difference. And so that data, and in part conversations with our colleagues, particularly on the East Coast, caused us to adapt ESRT to a remote format, which we live streamed across the country to about 100 different emergency and surgical MDs back in April of 2020. And now we've been refining this format in order to share ESRT with other groups. So we've learned a lot about how to implement this. It's a challenge, but is certainly possible. I won't talk about that here, but if anyone is interested, I'm very happy to share everything that we've learned. I can say that our efforts to hone implementation and delivery have helped us to get ESRT programs started at a number of different institutions, particularly around the US, but also over in your neck of the woods at Swansea Bay University. There's both a surgical and a medical school group there medical student group that are implementing this. And then the last thing I'd like to say is that one of the things that we've come to focus on more recently is moving away from having our bar simply set at helping people not leave the field or helping people not commit suicide, which are certainly important things, but seems like a bit of a low ask in terms of what we hope to get out of these careers that we've invested so much in and that impact so many other people's lives. And so what we've begun to look at is how can we characterize sort of the opposite of burnout? So instead of practically languishing, how can we characterize flourishing? And in fact, the mental health continuum is a widely respected and widely published measure that conceptualizes flourishing as having social, emotional, and psychological well-being and positive functioning. So if you recall, this sounds something like the CDC's definition of what well-being should be. And so I'm going to skip through that video. But when we started looking at flourishing in 2019, what we saw was sort of interesting, that while 42% of our residents, now this is just UCSF locally, this is about 80 individuals, while 42% of them registered as having very high perceived stress, almost 60% of them scored as flourishing. And so how did this make sense? And what was striking to us about this is that, in fact, we know that, for instance, in the first trial, which involved greater than 250 US accredited general surgery training programs, when work hour restrictions were implemented, many benefits came from that. But one of the benefits that didn't come, that was expected, was that it did not reduce the stress or improve the perceived well-being of trainees. And so what they found when they drilled down on that was, in fact, when people were told to leave the hospital sooner and it was mandated, they felt less stress at home, but they felt more stress about not being at work. And so it speaks to this complexity and this sort of inextricableness of our work and our lives that happens when one does work like we do. So digging down on this a little bit further, we just finished wave one of a study looking at flourishing in residents at 16 different academic institutions in the US. And this was with an eye towards understanding if this measure could be validated among trainees, surgical trainees. And indeed it is. You can see in this table where there's the green boxes that flourishing does have positive correlation with all of the main metrics that we're looking at right now in terms of what we think well-being is in surgeons. So positive mindfulness, positive personal accomplishment. And then we included some factors that come from workplace science. So job support, job control, job demand. And again, those also reflected on what we know from the literature as correlating positive elements with high flourishing. What's also interesting about this table is that it helps us start to look to see what's the most impactful area. So for instance, if you look at the top, it shows that personal accomplishment has the highest odds ratio in terms of correlating with high flourishing, which is wonderful, except how do we influence personal accomplishment? We don't really know. The only intervention that we know directly that has been demonstrated in the literature objectively to influence personal accomplishment is in fact mindfulness. And so I'm sorry I'm going over a little bit. I'll be done in just a few minutes. But the last thing I wanted to share with you is that we then also looked to see what kind of framing of the world do our flourishers in this collection of 300 residents from across the country, how do they think about their jobs and what matters to them? And so we asked this very kind of simple, crude question, but it was impactful. We asked, when it comes to your daily work experience, please rate from 0 to 100 how important it is to have ... So number 1, skills to manage stress, so like specific training. Schedule predictability, which was actually 2 questions. It was 1, when you'll next have time off, like a weekend off. And then 2, a separate question, when you'll get to leave each day. We asked about time with patients, a team that likes you, time in the OR, and then recognition of your work or effort. And what we found was that, well, several interesting things, but I think the most interesting was 3 things. 1 is that time with patients was ranked as the least important. And that was kind of striking. And that was across males and non-males and all PGY levels. We also saw that there was a statistically significant difference between the importance that males and non-males gave to skills to manage stress, with non-males seeing this as much more important, and non-males seeing reporting a statistically significant greater sense of the importance of feeling that they're part of a team. So I think the best way to interpret this data is simply to say that if we're looking for where to target interventions, and we recognize that perhaps males and females or people of different races or ethnicities may be experiencing surgical training differently, which we know is true, then we might need to look at some of this information to understand where to target. And the last thing I'll mention is that we then did this latent profile cluster analysis, looking to see what are the characteristics of the group with the highest prevalence of flourishing, and then what are the characteristics of those with the lowest. And I think the most, there's a lot of interesting things here, but kind of the most standout thing is that the latent profile, the profile cluster with the highest prevalence of flourishing, was found in individuals who most valued having skills to manage stress, having advanced scheduling, so just knowing when they were going to get a weekend off in the future, team bonding, OR time, and then recognition of their work. And then what I think is striking about these columns on the right is simply that the lowest prevalence of flourishers were found in groups of people who just couldn't really discern what was important to them in terms of skills or qualities to make work more satisfying, or those who just felt like nothing was. I'll just say in closing, I want to reiterate what Dr. Moulton was saying, that this really is a situation that involves this inextricable collection of factors that are individual, systems-based, and institutionally or culturally based, that we really do need to be looking at things that influence all of these. And then my last parting comment would simply be that we all need to be thinking about, is well-being and well-being resource investment a nose job or a cleft palate repair? So by that I mean, is well-being elective, something that makes us feel better but isn't really necessary, a matter of personal choice like a nose job, rhinoplasty? Or is it fundamentally necessary? So something that without we cannot function properly. We are effectively handicapped, therefore making well-being a fundamental need. Sorry for going over, and thank you for inviting me to share this.
Thank you very much, Carter, for that wonderful talk. It just highlights how important mindfulness is actually important to us as surgeons, but probably also equally to the rest of the team. We've got a question. How would you manage the 3 to 4% of trainees where, despite ESRT training and practice, they still have high levels of anxiety?
Yes, well, this is, again, it's not one size fits all. And so that's something we've been distinctly seeing through all of this research. So just as there's not going to be the same ideal approach for males and females or people of different races, there might have to be nuances. It's also true that some people's mental health status is in a different category. And so people that have clinically relevant anxiety probably need access to the traditional resources that we know help address clinically relevant anxiety, like psychotherapy. And so more programs in the United States have been working to overcome the cultural stigma and then the logistical hurdles that have been historically in the way of people utilizing those types of resources. So this is a very active area of change and resource investment here.
And question from me, I mean, you've used the ESRT mainly on the younger doctors, the interns. What about rolling it out to attendings, or what we call consultants here? What's the attitude towards that?
Yeah, so it's been very well received. We've done this now both in person back in 2019, and then, as I mentioned, remotely to physicians across the country in the last 18 months. And it has been really almost universally very well regarded, except that it seems to give people this, in many instances, this sense of having to choose. So for instance, with our residents, we control their lives for this vast block of every day, and we can move around the chess pieces to make 1 hour once a week for 5 weeks. But for consulting surgeons, what we call attending surgeons, when we offer these courses, we're asking them to take what is already this incredibly small wedge of discretionary time and devote an hour of it to this type of practice. Now, one can argue, well, taking care of yourself should be worth it. But quite frankly, if what you're having to choose between is taking care of yourself and seeing your children, or seeing your spouse within a 48-hour period, most people are going to choose rejuvenating by being around their loved ones. And so what this speaks to is that for those of us who spend so much of our lives either literally physically at work or in the process of work, even when we're outside the building, that we need to have interventions that boost these things, that are not, where the onus of these are not put on people's individual time. These need to become workplace infrastructure resources. And before people scoff at how impossible that is, it isn't impossible at all. There are incredibly highly profitable and productive and vast institutions that are doing this, like Google, like Microsoft, like Apple. And they're showing that it only increases people's job satisfaction and productivity.
Yeah, thank you so much, Carter, for your time.
Thank you for the invitation. It's really a pleasure.
Thank you. We'll move on to our last talk for the afternoon. Ben Tipney.
He's here.
Is he?
Yeah, I'm here.
Ben Tipney is going to talk to us about increasing psychological safety in a team. Now, Ben was an international athlete. He competed in several world championship events with the Great Britain rowing team whilst he was completing his degree in leadership and sports psychology. After he retired, he turned to coaching, and within 4 years had produced a national champion crews and international selections in rows in both UK and South Africa. So he's gone on to apply the principles of high-performing teams to other areas. And after several years of working with corporate and individual clients, he's also started to work with teams in healthcare. So Ben, over to you.
Thank you very much, and thanks very much for the kind invitation. So hopefully everyone can see what I'm sharing here. Yeah, I think amazing talk so far, and I think in full-blown imposter syndrome right now. After I'm afraid I'm not an eminent professor. I just used to make boats go fast. Yeah, like you kindly said, my background was in international sport, and I suppose one of the things that I noticed in coaching was there's a clear necessity for high levels of technical skill. There's no getting around it, in the same way that you need a high level of technical skill to be a brilliant surgeon. There's no getting around that. And in rowing, there's also a necessity, and it touches a bit on what Peter was talking about, physical conditioning. People had to be really fit and strong to go fast. It's a physical sport. But what was interesting to me is if you could develop athletes to be very fit and strong and very technical skilled, it gave you a high ceiling of potential. It gave you a high potential for performance. What it didn't give you was consistency of performance. So consistency of performance came through a number of factors, but in particular, how people manage pressure. So how they perform when it matters, and how people function with others in a team. And I guess, the short version of the story is you kind of spend an awful lot of time working on these things that have nothing to do with rowing. And yeah, I've worked very broadly, but the last 7 or 8 years has been specifically focused on working with teams in healthcare. And I found Professor LeBarry's talk really interesting. I'm a big advocate of mindfulness. I used it in my own life for a while. I definitely noticed when I drop off practices myself the impact that it has. And I'd like to sort of speak to the relationship between stress and performance to start with, and she used the Yerkes-Dodson graph, and it's one that I think it gets used a lot, but does it give us a complete picture of human performance? So the Yerkes-Dodson experiment was an experiment in 1908 on rats, and yet we still talk about it as a complete model of human performance, and it's not wrong as such. And I think that the trouble when we use this is it suggests that the goal is to reach an optimum amount of stress. So when you look at the X and Y axis, it suggests that a bit of stress is good, a medium amount of stress is ideal, and too much stress is bad for us. So that the goal should be around stress, managing the amount of stress we're under. And the problem with that is that stress is typically, it's about external stimulus, and we can't control that. And I mean, she used a really brilliant phrase, which is stress is inherent in medicine. I mean, I think it's inherent in life, but certainly in in environments where we're, I'm just thinking about what Professor Moulton was talking about in terms of identity, especially in areas where identity is strongly connected to what we're doing, elite sport, medicine. So if the stress is there, can we actually control the amount we're under? So is this the model we want to be using? And there's some brilliant research by a guy called Sam Vine, who's at Exeter University, looking at, I mean, this is a lot of research has been with athletes, but also increasingly look at research in the surgical space as well. And what they're looking at, and what they found is, indeed, that as stress increases, typically, to start with, performance increases in both motor skill and cognitive function. And then interestingly, one of two things can happen. Either performance still increases or levels off. So you get this kind of sustained high performance as stress continues to increase. And I think it's worth saying that the conditions where performance is high, as well as stress being high, it's still wearing on the system. We're talking about burnout, and I often liken it to driving your car in third gear at 70 miles an hour. The car can do it bouncing off the red line, but it can't do it indefinitely. We do need recovery. So high performance in high stress environments, we still need recovery from that. And I think this is why, I work with a lot of clinical people, and interestingly, the people working in the mental health sector are talking about their wave is coming now. Their peak from the pandemic is coming now, because we're now seeing that people who've been working really hard under high stress circumstances but performing at a high level are now kind of running out of energy, essentially. So interestingly, so we can have very high levels of stress and very high performance, or we reach this point and you get the kind of traditional Yerkes-Dodson effect, which is you reach a point where stress suddenly impairs your performance, and it's realistically, it's more like a drop off a cliff. It's not really usually like a nice parabolic N shape or reverted U. It's usually like a climb and a drop off, and we've probably all experienced that moment where suddenly it's like you can't think, or the red mist descends, or whatever, the fight, flight, or freeze moment. So what's interesting to me is what are the factors that determine whether, and Professor Labarre used the word challenge and threat, and this is what they're looking at is, what are the factors that dictate whether under the same level of stress, so you could expose an individual to a given level of stress or anxiety, and you could get either a high level of performance or a low level of performance. What are the factors that influence that? And interestingly to me, I'd be interested in Professor Labarre's take on this. Like, my understanding, I studied mindfulness at the Study Centre for Mindfulness at Oxford University, and the framing there, mindfulness isn't about reducing stress, it's about helping us reframe stress and change our relationship with stress, and actually that's what helps us, and I guess that's borne out in my experience. So the factors that there's kind of three, I guess, key factors that govern our relationship with stress is, and we'll come to those in a moment, and there's some interesting research from professional football. This is a huge piece of work, and they're looking at penalty kicks. Now, penalty kicks are an interesting study because it's a very discrete skill. It's a very isolated skill, and it's the odds are massively in favour of the person taking the penalty. So this is across professional football, men's and women's game, international tournaments, top level leagues over a number of years. So in a penalty, in training, at very low, so in training where there's no pressure on you, it's a low stress environment, the success is typically about 85%. So 85 out of 100 kicks at professional level, they'd expect to score. In matches, so high pressure matches, you're talking knockout competitions. If it's a shot to win the game, i.e. you score now and your team wins, it goes up to 93%. So this is an example of stress improving performance. Where it's a shot not to lose, i.e. if you miss this one, your team is knocked out. That goes down to 63%. Now, the level of stress is the same. So if you're a team in the World Cup final and you're in a penalty shootout, the stakes are the same. But if you get to a point in the shootout where the next shot means if you score, you win, there's not enough shots left for the other team to come back, 93% chance they're going to score that. If you're at a point where if you miss this one, there's now no longer enough left for you to win, it goes down to 63%. So the kind of shot to win or the shot not to lose makes a massive difference. It's a very subtle but important difference. And basically, it's going back to Sam Vine's research. What they found is when you put people in situations where it's essentially a shot to win, you see high levels of adrenaline, but without the shot of cortisol, which is what gives us the impairment of cognitive function. Whereas the other one, the sort of threat or fear response, the adrenaline and cortisol together is what impairs the performance. So a question I have is, what are the factors in our work environment that govern whether our environment is threatening or challenging? So the predictors are how we frame stress, how we talk about it. Do we talk about stress as a bad thing? So when I was part of the GB rowing team, they were just starting to look at this, and now I know they've collected quite a lot of data on the fact that the athletes whose attitude to nerves is, oh, I've got nerves, I need a strategy to reduce my nerves, i.e. nerves are bad, stress is bad. No matter what strategy they employed, those athletes tended to perform worse under pressure. Athletes whose attitude to nerves were, oh, nerves, that's my body getting ready to perform. This is normal physiological response to something I care about. So their framing of stress was that as it's a normal biological function, perform better under pressure. And there's a plethora of research around this in terms of catastrophe theory and sports psychology. So how we frame it, and actually there's a lady called Kelly McGonigal who does a brilliant TED talk around this. It's called Change Your Relationship with Stress, which is worth a watch. So the second one is our perception of our ability to cope. So to perform well as a surgeon, you need to have the technical skills necessary to do that, and the non-technical skills. How the extent to which pressure affects our ability to execute those skills actually is more dependent on perception of our ability. So if I have a high level of technical ability, but I don't really believe in my ability that much, under pressure, I'll tend to have that initial lift in performance and then a drop off, the traditional Yerkes-Dodson effect. If my perception of my ability matches my ability, i.e. I have a high level of skill and I believe I have a high level of skill, I'm more likely to go into that challenge response where you get that rise and then a level off. Remember, we can still get burnout. And this is why peer mentoring, Atul Gawande, who wrote the great book, The Checklist Manifesto, says every surgeon should have a coach. You know, every great sports person has a coach, someone to help us, to mentor us, to help us build confidence. So experiential learning, simulation with supportive debriefs, peer mentoring, that's why I think these things are so important. And then the last one, which is what I want to talk about for the next 15 minutes or so, is the level of psychological safety, so the social predictors. And I think, Peter started touching on this towards the end of his talk around, hierarchy gradients. So I just want people to think for a moment about this term, psychological safety. What does it mean to you? So I'd just like to invite, and hopefully this will work, to put in chat, and I'll have a look. What do you understand by the term? Or you can put in the question box potentially, because I don't think I can actually see the chat coming up. I think it's been enabled, but I can't actually see it. This is just my kind of slight obsession with doing interactive talks. I struggle to do things in a very one-way capacity, but it looks like that might not be working from a technical perspective. So let's not worry about it in the interest of time. But the reason I ask this is because psychological safety is something that's superficialized to just being nice to each other. There's a great project called the Aristotle Project done by Google, who found that, among other things, the biggest factor that influenced whether a team was high performing or the performance of the team. Google only recruit people with high levels of technical skill. That's reality. But when you put those people together, what governs whether they're a really high-performing team or not? And psychological safety was the #1 factor. And I saw someone on social media put, so drum roll, please, after 2 years of exhaustive research, Google have concluded that the secret to high-performing teams is being nice. And I remember thinking, is that what psychological safety is about? And I had the fortune to meet a lady called Professor Amy Edmondson at a conference a few years ago, and having read quite a lot of her work. She's a psychologist, professor, researcher at Harvard University in this area, and actually a lot of her research is in healthcare. And I love this. When we had this conversation, she said, I get really frustrated about that comment about it's just about being nice. She said, psychological safety is not about being nice. It's about creating an environment for what she calls safe conflict, an environment of give and take where we can constructively, and Professor Brennan earlier was talking about respect, where we can constructively and respectfully disagree with one another when we have to, rather than tiptoeing around on eggshells. And so the clearest definition of psychological safety is a shared belief held by members of people in the team that the team is safe for interpersonal risk-taking. So an interpersonal risk. So let's say, one of the people I've heard speaking this morning, really experienced consultant surgeons, I come in as a trainee, I'm doing my rotation in that area. As a couple of people have touched on already, someone might have told me in my induction, raise your concern if you see something you're not happy about. But if I see someone really experienced who I look up to doing something that I'm not sure about, to me, saying something constitutes an interpersonal risk. Now, I might know intellectually, logically, that the risk to the patient for not saying something is much bigger than the risk to me for saying something, but the risk to me is immediate. It's known, or I think it's known. And this is, typically we see this, with the response to climate change versus the response to COVID. You say to people, stop flying airplanes and stop eating meat, or we won't have a planet to live on in 50 years, and people shrug their shoulders and don't do anything about it. You say to them, wear a mask or you might die of COVID, people put on a mask because it feels immediate. So this kind of thing about an interpersonal risk, creating an environment where people feel safe to do that. And it's so an environment characterized by interpersonal trust and respect. We've heard these words already. Trust and respect, people are comfortable to bring themselves to work, not a sort of smaller version of themselves. And a sense of confidence that others around them won't punish, reject, or embarrass them for speaking up. If they share an idea and it's not a great idea, no one will make them feel silly. If they make a mistake, they won't be chastised for that mistake. So that's essentially what we might call a psychologically safe environment. And I think this is particularly pertinent because, we get a lot of comparisons with healthcare and aviation, healthcare and sport, healthcare and F1, all these kind of things. And there's loads to learn from lots of different sectors. I come from a family of pilots, so there's a whole other conversation there. And I'm always a little bit cautious. People often ask me about the lessons from elite sport. And I think there's a lot of good stuff you can take. But there's a key difference. And to me, when I think about the healthcare teams I work with, in sport, you have the luxury. It's largely the same people every day. Yeah, people move in and out of a team a bit, but it's often through choice. Whereas in healthcare, particularly in large surgical, I know sometimes in small specialist units, you might have a consistent team, but some of the general surgery units and some of the large hospitals in central London, there's hundreds of people, it's different people every day. A lot of Amy Edmondson's research is about performance from unrehearsed teams of people who don't know each other. And she talks about this concept of teaming, producing high performance from teams of people who don't know each other very well. And her case study on this, and again, there's a good TED talk, if you like a pithy kind of approach to this, and it's about the rescue of the Chilean miners. It was deemed an impossible problem, but as many of you here will remember, they did successfully rescue them. And this was cross-sector, cross-government, cross-country, cross-specialty teaming to solve a problem. And she talks about a number of factors, professional, situational, and humility, which I'll come back to, and having curiosity about what others bring. Spawns psychological safety. So, if I know someone really well and they behave in a particular way to me that seems a bit odd, but I know them, I can kind of explain away that behavior. Whereas if we don't know people that well, those behaviors have a bigger impact. So our ability to create or damage psychological safety is that much more important when we don't know the people that well. And I often talk a lot about micro behaviors, which I'll sort of circle back to. And so this is the Aristotle project from Google. So there's a number of key points you can take out. And we've heard things about, clear roles, plans, structure, meaning, which we've touched on. But psychological safety, this feeling able to take risks and be vulnerable in front of one another. Amy Edmondson's written a book. And by the way, I have no commercial connection to any, to her or any of the books or anything like that. She's written a book called The Fearless Organization, or two actually. One is Teaming, which is largely theoretical, whereas the fearless organization is a bit more about practical application. And a lot of the research cited in that book is in healthcare. This isn't from the book, the next two will be. This one is from a couple of years ago across 137 acute trusts in England. So where people reported feeling more able to be open about concerns, those hospitals statistically were more likely to have about 6.5% less mortality rate. So we know there's a connection here. This is a different study. This is detailed in the Fearless organization. This is a study from Belgium. And this is where what they looked at was where we had a focus on safety standards. What I mean by that is people and management positions in the organization, making it clear to everybody in the organization, will you have a responsibility for patient safety? So kind of putting an onus on everyone in the organization to think about and consider patient safety is important. You know, we need to do better to keep patients safe. So basically you're ramping up the pressure around patient safety. Where you did that, but you didn't work on psychological safety, people actually made more errors. Basically what you've done is you've created a threatening environment by putting pressure on people, but without providing the support and helping them feel safe enough to have those conversations. Where you put the pressure on people to improve patient safety, but you also improved psychological safety, people actually made less mistakes because you're creating a challenging environment, not a threatening environment, going back to Sam Vine's research. And the last one is from cancer teams and quality improvement. Teams where there was a low psychological safety relied on what we call silent workarounds. What that means is when they see a problem, they just kind of on the day find a way around it, but they don't really talk about it to anyone else. Whereas where there's high levels of psychological safety, they focus on diagnosing the problem and improving the process. So they talk about it openly. And maybe this sounds, you know, and this is where Peter and I might diverge a little bit in terms of I'm always a little bit cautious about this term common sense because, you know, as one of my coaches told me, sense is not common. What's common sense to one person isn't common sense to another. But, you know, I think most of it sounds obvious, doesn't it? If we're able to have these conversations, we will perform better. So there's a kind of, you know, a sort of a socio-emotional component to this where we cognitively perform better in psychologically safe places. But there's also a kind of practical communication issue here that where we feel able to have these conversations, the organization is able to learn rather than just individuals learning from things that happen. So how do we do it? And I think this is key. And there's some interesting stuff from the Children's Hospital in Minneapolis from Judy Marath, who's the COO in our organization. She describes 3 stages to this. And the first is setting the stage. And this is widespread education on just culture and human factors and systems thinking. And so human factors and ergonomics as a science is partly about non-technical skills you've heard about and our kind of own attitudes and behaviors, you know, looking after ourselves. But it's also and kind of arguably mostly about all the external influences on human behavior. So how the environment, the technology interface, how that makes our job easier or more difficult, safer or less safe. When we understand all of the factors that influence human behavior, performance and well-being that actually aren't about our internal systems, but are about the external systems as well, what that does is it encourages the search for what happened, why and how, rather than who did it. So having a more systems-orientated approach rather than an individualistic approach. And what this does is it in turn kind of helps reduce fear of blame. And there's a brilliant quote by Edmund Burke, who's an Irish politician from the 18th century, and he says, "No passion so effectively robs the mind of all its powers of acting and reasoning as fear." It's that threat state. And a big part of this is reframing and destigmatizing failure. You know, failure is not a bug of learning, it's a feature. We all make mistakes. You know, Professor Brennan talked about that eloquently earlier. And the more people in positions of influence are willing to talk about their own mistakes and failures, the more socially acceptable we make it for others to do the same. And the more we do that, the more we learn and the less threatening the environment. So that's the start. The second part is inviting participation. And we talked a little bit today about briefings and things like that. And we do various things, pre-list briefings, you know, on the wards, they do safety huddles. But in those situations, it's, you know, as Professor Brennan talked about, it's not just putting on the hat, but how do we bring people into the conversation, standing there and saying, look, I won't anticipate everything that's going to happen today. So if you see something you're not happy with, please tell me. You know, and I think this thing that communication and confidence and humility are not opposites. People think often, you know, admitting you don't know stuff and being confident are different things. And actually, true confidence is trusting your ability whilst also acknowledging that there'll be stuff you don't know. And that's where we're at in medicine and life. Life's too complex now. We can't possibly have all the answers. And proactive inquiry. So don't wait for people. That you get the odd really confident individual who will ask and question off their own volition, but particularly when people are inexperienced, we have to bring them in and actually then really listen to what they have to say. Ask a question with the intent to understand, not with the intent to reply. And developing an attitude of curiosity first and judgment second, if necessary at all. So being curious is vital in this. And we talk a lot, so we have a lot of, comparisons, often, cockpit of an airplane or Toyota's production line in a factory. The thing is, a production line in a factory is simple work. It's repetitive. It's the same every day. So what you do is you clearly define a right and a wrong way to do things. So my brother's actually recently left the aviation profession, but before, going to simulator twice every year. There's a right and a wrong way to deal with an engine failure. And as Professor Brennan said, we can learn stuff, but we've got to be careful with the direct comparisons. There's a clear-cut right and a wrong way to deal with an engine failure. So what we do is we have a best practice that can be identified. So if people get it wrong, whether it's a failure of their technical skills or non-technical skills, we fail them, we tell them it was wrong, and we give them corrective action, and then we test them again. So there's a clear-cut, we're not talking about judging them as a person, but judging their actions. And there are bits of healthcare, obviously, where that's applicable. There is a right and the wrong way to use the checklist, for sure. There are certain things where there's a really clear cut. There's a right and a wrong way to do things like radiotherapy. Certain things are very rule orientated. But a lot of healthcare fits more into what we call the VUCA, volatile, uncertain, complex, and ambiguous, where particularly, I guess, innovative surgery or emergency surgery, things where there's a lot of uncertainty, there's unknown unknowns, there's complexity that arrives, things that we didn't anticipate come up, and there's a level of ambiguity, and there isn't a clear-cut right or wrong way to do things. There are a series of possible options, all of which will have kind of positives and drawbacks. And it's in these endeavors that we have to have curiosity. This is why Google talk about it, because Google are trying to break new ground. They're trying to do things that have never been done before. So what they talk about is that we have to be curious and we have to be willing to fail. They don't mean fail in our ultimate endeavor. They mean fail in our smaller bits getting towards it. And it's this kind of thing about being curious. And being curious doesn't mean we have to agree. I can be interested in what you have to say and accept that I may or may not agree with you. And as Professor Brennan was saying, I can be curious, but if I'm the decision maker, I can listen to what you have to say and then just agree with you and do what I was going to do anyway, because I might have more experience and have decided that's a better course of action. But the point here is that really clear-cut judgment is great in very simple work, less good for complex work. So how we respond is really important, because showing appreciation for how for someone giving you information is absolutely vital. It doesn't mean, it's not the same as agreeing with them. You're helping, if you imagine you've helped someone get over this hurdle of sharing information with you, you've managed to bring them into the conversation, and they share something you disagree with and you shut them down straight away, they're almost certainly never going to do it again. It's worse than not doing it at all. So if you bring someone in and they share something with you and you don't like or don't agree with it, we have to appreciate that they've done it first. So thank you, I appreciate you sharing that with me. And then you can choose to disagree with them. And we have to think about how we do that, and how we have that conversation. So destigmatizing failure, we talked about, and the more complex the work, the more important it is to praise effort and strategy rather than the end outcome. So in very simple work, it's important that, if my brother who's in the simulator pulled the wrong lever at the wrong time, dealing with an engine failure, that's focused on, or did it right or wrong, that's focused on. But in complex work, it's, if you put someone in simulation, I think it's probably to argue it's more important to talk about how they reached the decision than what decision did they make, because the chances of them being exactly the same situation again in future are slim. But how they used the resources, how they had conversations, how they made their decisions, how they got information from others to update their situational awareness, that kind of thing. It's the effort and strategy that's important. And additionally to this, and this links into just culture, which is a whole other topic, sanctioning reckless acts and sabotage, and differentiating people who show a clear disregard for safety. They're just not fussed about safety. Or sabotage, people creating harm deliberately, clearly differentiating that from sort of genuine error. And that's obviously clear, really important. So I describe psychological safety, and I apologize, you're running a few minutes behind, just the last couple of minutes, like a delicate vase on a table. So this, it's, and again, this was touched on earlier, a lot of things are hard to create and easy to damage. So psychological safety is like this delicate vase. It takes years to create and it looks beautiful, but it's very easily broken, and it sits on a table that made up of our behaviors. And the behaviors are kindness that we display to others, empathy, or listening with the intent to understand, civility, treating others around us with equal respect. And there's a great movement, Civility Saves Lives, which is worth looking at. And assertiveness, which is simply being willing to share information with us, but in a way that treats their rights and ours with equal respect. So assertive behavior sometimes means not saying something because we don't believe it's helpful or productive in this moment, even if you feel like saying it. Sometimes it is about having an uncomfortable conversation. But those behaviors are a byproduct of our attitudes. And this stuff sounds simple, but one of the things that I've realized is that the stuff that matters is simple but difficult. So a lot of the stuff that really makes a difference, it sounds simple, right? So be curious. I need to bring with me an attitude of curiosity, be deeply and genuinely interested in what others have to say, what they bring, their talents, their perspectives, recognizing that my perspective will always have a limit to it, and I won't ever have all the answers. So humility to recognize that I'm not always right, that sometimes people will see things that I don't, and that doesn't mean I'm not good at my job. Respect, so treating others with equal respect. There might be a decision-making hierarchy, as was touched on earlier. That's the reality of high-risk environments don't tend to work very well with a democratic approach. It's too time-consuming. There has to be a decision-making hierarchy, but you can have a decision-making hierarchy and still treat others as equal human beings, so equal respect as a person. And trust, so trusting people unless they prove themselves to be untrustworthy, rather than starting cynical unless they prove themselves to be trustworthy. And this sounds simple, but actually this requires ongoing work. And my wife will tell you, I regularly get this wrong. I'm not always curious. I tell her what I think without listening, right? I have conversations and she'll say, where's your evidence for that? Or is that just an opinion you've created? I lack humility. We're all guilty. This will never be finished. We're all a work in progress. So for me, but if I work on these 4 attitudes, the legs of the table, it will manifest in the behaviors. And that in itself will create psychological safety. And you can't measure this stuff at an organizational level. There's too much variance, day-to-day, team-to-team, group-to-group. It exists at the level of the team. And I love that because it helps us recognize this is something we can all directly affect all the time. And Amy Edmondson talks about commitment. This is a daily thing. It's never finished. Anyone who says, yeah, we've cracked psychological safety in this organization, we don't need to worry about it anymore. Rubbish. It's never finished. And Chris Turner, who started this movement called Civility Saves Lives, which some of you might have come across, well worth looking up. It's about the impact of incivility and rudeness on performance, which is very significant. He talked about call it out with compassion. I love that. And what he's basically saying is, if you see behavior that you think is inappropriate, remember that you promote what you tolerate. If we don't say or do anything, it will keep carrying on. And then we're sort of inadvertently saying that we think it's okay. So call it out. Call out behavior that we think is not respectful, is not humble, is not curious, but do so while recognizing the person exhibiting that behavior is also a human being. And you don't know what's going on for them at that moment. You don't know what's driving their behavior, what's in their bucket. So call out the behavior, but do so with some compassion. And that is the sort of thing that creates change. That's the sort of modeling that was talked about earlier, I think. People often ask me, when does team building start? And we talk about pre-list briefs and stuff like that. And of course, that's a big function. But actually, to me, team building starts in every moment of every day, every interaction you have. When you walk past someone in the corridor, when you bump into them in the coffee room, it's those micro interactions that you have. It's the ripples in the pond. We all create ripples every moment of every day with every interaction. Whenever you see, or whether you're in verbal or audio range of another person, you're creating ripples. The question I would sort of ask, what ripples do you want to create? Our impact is never neutral. we are improving or degrading psychological safety in our teams whenever we're interacting with the people around us. So look, that was again, and probably another a whistle stop tour through. Thanks very much again for inviting me to be here with such an amazing group of people, and thanks to everyone else that I've listened to today. I've learned plenty myself from listening to everyone else. I look forward to some more conversation.
Thanks, Ben. That was a fun.
Oh.
Thanks, Ben. That was a fantastic whistle stop tour, as you called. You kicked off saying, look, you're having lots of professors and I feel like an imposter, but you pulled everything together. There were a few things which you said, which we encounter as surgeons, the adrenaline rush and positivity. In fact, one of the things which most mentors or coaches will tell young surgeons is the rush keeps you going, but also have your mindfulness time and your downtime. And some researchers would say surgeons die very soon after retirement because they lose that adrenaline rush. There have been fantastic comments about your talks. Curiosity first, judgment second, brilliant. Shot to win versus shot to lose. But at this point in time, there's two things which I want to do. One, we're really, really looking forward to the masterclass which you have promised the SCTS members, which is part of the engagement process which the society is offering with Ethicon. So you would have seen the flyers in the break. We thank Ethicon who have supported us to offer this masterclass to our members and the wider surgical fraternity. Why do you think the level of performance increases with the level of stress at all? Is a question from one of the delegates.
Yeah, I mean, as Professor Barrows was talking earlier, it's just simply our normal biological response. So once upon a time, it was the when there was a rustling in the, remember 10,000 years ago, we weren't an awful lot different biologically, but the world was very different. The world was very simple, but it was also very dangerous. So the rustling in the bushes could have been anything. So what we need is an initial level of increased alertness, but we still need to be able to think, because like what's going on. But we need then to be able to recognize the difference between, like I say, the need to engage with our own tribe, our own people close to us, or then either fight or run from a predator or a neighboring tribe or something like that. So it's just our limbic response. It's just that flood of cortisol adrenaline. It's the response to potential threat. So, and when you're being chased by a tiger, your ability to think and make complicated decisions is limited. If you stop and think when you're being chased by a tiger, you get eaten. That's why the fight, flight, freeze response is important. So it's the body's getting ready for action is a great way of describing it, I think. And that's, I don't know if that's answered the question. I would really recommend Kelly McGonagall's TED talk on this, about our relationship with stress and seeing it as just a normal biological response. The limbic system, being a very basic part of the human function, has no way of knowing that it's now 2021 and it's not a tiger, it's standing up in front of a group of your peers to make a presentation. You're not going to die, but you can still get the dry mouth and the sweaty palms and everything else. And a bit like Professor Brennan was talking about as well, it's the same part of the brain that tries to distract you from whatever you're doing if you're hungry or thirsty, because again, the limbic system has no way of knowing that, again, you're not going to die of thirst in a hospital, but if you're not hydrated and well fed, then it will distract you from whatever you're doing until you attend to that function. And if you think about it, it's a really good piece of evolutionary design. It's there for very good reason. And I think that's really important. And that's, to me, the big thing I take out of mindfulness is it's not about judging our reactions or our emotions or our biology. It's just about understanding it and noticing it. And notice our responses, notice our emotional responses or our thought patterns, observe them, sit with them without judgment. Yeah.
But this probably was a question to the surgeons, but I think I'll let you take first and then probably ask Mike, who's on the call as well. In a critical situation during surgery, if the team leader is at a loss to proceed further, how can the assistant persuade the leader to tide over the situation in a particular better way without offending?
Yeah, well, I've probably spoken enough for a little while. I'll let someone with surgical experience pick up that. But I'm happy to kind of comment on some bits and pieces, but I'd perhaps hand someone with surgical experience on that.
Mike?
It sort of echoes what Ben's been saying. I think it's all about how you set the culture of your room. I don't always succeed by any means, but I try to have a structure where that, if people feel that there's something that's being missed, if I'm saying the wrong thing or I'm doing the wrong thing or something's not going right, that somebody will feel that they're in the right position to say, well, how about trying this? Or I wonder if we, might think about asking them or something. And so I think it's almost before you've started, you've set the culture for that. And it's good to be reminded of that, the phraseology of, if you see something that I'm doing what's going on in the room that you think I haven't spotted or are looking for, a moment to come in, and please, feel free to say so, and to, because, focus is keeping the patient safe. And I think trying to run your room with that sort of culture, I think is as Ben says again, is an ongoing effort. It's not a one-off, we've got this sorted, we've now got patient safety nailed. It's a daily, hourly, minutely experience, isn't it? So I think it is partly that you have to set the tone of the way that you run the environment you're working in. And then I guess it's just finding the right set of words for that individual. If there's an individual interaction, hopefully you've got something where you can key into that discussion. You could, direct someone to, in a way, to get them through that tricky moment. I'm hopeful that as a generation of surgeons now, we are a little bit better than our forefathers, many of them were amazing technical surgeons, amazing at doing the stuff that they did, had all got enormous experience and had done loads of it, but perhaps hadn't sort of thought so much about this sort of thing because there was this very strong pyramidal structure, very high stakes, very sort of complex environment to work in. And I think that hopefully now we're flattening that sort of pyramid. We understand that, you can't always know everything, and there are moments where you are going to need help from others. And I try to do it when I'm in a difficult situation. I try to remember to step back and say, this is what I'm thinking of doing. This is why we're doing it. Is there anything else that anyone else has spotted that might help us in those discussions or decisions? And so again, that comes back to how you set the culture in the room as say the consultant or the lead or whatever it is that's doing, whoever's doing the operation. But I think it is, I understand, a very challenging moment where you're perhaps thinking, oh my goodness, I know what to do, but this person isn't seeing it. That's a real moment, isn't it? But you've got to go back to what's best for the patient. It's that you've got to focus on.
Mm. I think that's, completely agree with everything you said there. And I think as the person who's trying to raise a concern and perhaps it's not getting through, it's the important thing, I think, is remember that we're not challenging the person, we're a behavior or an action. And I think that's really important. And that starts, and sometimes people don't like being told what to do. So often it's how we say things. So you can make suggestions and ask questions. We often, you talk about hint and hope, where we drop hints about what we think. But if it doesn't work, sometimes actually, and it sounds obvious, but simple repetition, because often, and when we think about task fixation, and we could probably all think about times when we get the tunnel vision, we get sucked into a task and we miss things around us. And anyone, sure everyone here has watched, the Just a Routine Operation video by Martin Bromley, and being sucked into a situation and missing things around us. Sometimes people don't hear things, but not because they're deliberately ignoring you, but because they're sucked into situations, sometimes repeat. And then sometimes if someone said, how do we do it without offending? But we have to ask ourselves the question, what's more important? What I have to say or offending someone? And, you know, there's a kind of, it can't all be one responsibility. It can't just be the responsibility of the person raising concern or just the responsibility of the person setting the tone. It's kind of like a dual responsibility. We can't do it alone, really. So we do have to ask ourselves, is offending, and there's an acronym for it, PACE, which I'm sure people will have come across. So probe, alert, challenge, emergency. So probe being dropping hints. I'm just wondering if you've noticed. Alert, which is you kind of basically just repeating that. I'm a little bit concerned here. I'm not sure we're doing the right thing. And then repeating it a few times. And challenge, which is I have a concern for patient safety. And the you know, the last one, the kind of emergency, is stop now. And that's a very difficult place to go if you're more junior. And that goes back to, I think, what you were saying about setting the tone, that being able to create a place where people actually feel able to do that, and even physically intervening and things like that. And that's you know, some of us jump too quickly to the being very direct, which can get people's backs up. But equally, some of us are too hesitant too long. And that's a kind of personality and previous experience thing. And that's why kind of when we shut people down in conversations, that won't just influence how they work with us, that will influence how they work with other people in future. And then they won't go down that process with other people in future.
Thank you. I think I agree with that as well. I think you can also use the same sort of approach when you're actually training somebody who's doing the procedure, and you've noticed that there's some issues with what they're doing. Start off with the probe, and hopefully not get to the emergency. We've got another question. Is it okay to be a cushioning factor, for example, being a mediator, communicator for another member who may be difficult for the team, but may be better technically for the patient in the surgery?
That's a very interesting question. I don't know. I'm aware I've spoken a lot, and if anyone else wants to pick that up, I've got some thoughts on it, but I'm interested to hear what other people think on that.
Maybe Carol?
So can you just repeat the question? I didn't quite understand it. Is it better to be the mediator or the technician?
Where's the question now?
I think the question was around should we essentially tolerate or accept and find ways to work with people who are disruptive on the team, but technically. Was that the kind of premise of the question?
Let's make that the question then.
That's what I understood by it, but maybe I've misunderstood it.
No, it's an interesting question, and we have people here in our institution that are great researchers and great technicians, but awful teachers, and are toxic to work with. So, we tolerate them. I say we, being like my system here, tolerates them, and it's obvious that we tolerate them. So it sets a message. I think you're kind of talking binary, like should we accept them? I don't think we should accept those behaviors. And I think the institution and the system, whatever that is, whether it's at a local level or a bigger level, anything that you do that tries to change behavior towards becoming kind of a more psychological safe environment, I think requires the support of the higher level, and it's not going to happen overnight. And it has to come with, that person who is toxic is likely toxic from their own training, right? I mean, they've been produced by the culture and produced by the generation before them, and it's becoming less and less tolerable. And I think we have to continue to move that way. It's not really answering the question. I kind of feel like if it depends on what we're talking about, but some things are probably not tolerable. Abuse or violence or whatever. There's some things that we should not tolerate at all, no matter how technically brilliant somebody is. And then it depends on also how responsive to change or responsive to feedback they are. They're not going to change overnight. So, I think the whole system is changing, but it's going to take time, and along the way we're going to make mistakes. But it sounds like we're all kind of pushing towards a similar environment. I don't know if it's answered the question, but it's a difficult.
I think you have. I was just not very good at multitasking, as my co-host here is.
That's right. I mean, none of us are.
While we have you there, Carol, we'll pick up a question which was from earlier. Do you think that if we introduce a way to normalize the emotional response of our ups and downs in our daily practice might help in minimizing the impact of our fears to express our emotions and accept others' emotions?
You have like a really educated audience there.
Well, this is a trainee who's done a bit of psychiatry before becoming a surgical trainee.
Yes. So if we normalize the emotional ups and downs, will it help us with the impact of the complications? I think that's the question, right? For sure. I think that's why I believe we should normalize a lot of things. And I think right now what we're doing is, by keeping things kind of hidden or behind a curtain, we leave it up to the individual to figure it out and to feel these things that they're feeling without really having a language to understand them, and without understanding that they are a person or an individual embedded in a very powerful culture and system and environment. And so, I think when you give people the language and normalize things that say, you're not the only one who feels this, and you don't have to ask the question, am I cut out to do this? That, we all, I think after that, we feel, okay, now let's get on with our work and let's get on with trying to make this better for us. Like when I figured out it was normal, then why are we accepting this as normal? So I think, emotional ups and downs are a part of it, like we've talked about. I think that's why we're here. We're here because we're challenged and we love the challenge. And, that's why we're attracted to this profession. So let's learn how to embrace that and live a healthy, normal, full functioning life, and allow our trainees to come on board and live a full life, with what the consequences of this job is, but let's support each other in doing it.
Yes, Ben.
Yeah, I just was sort of building on that a little bit, just as you were talking there. So touching on something that came up earlier, I think we need to be a little bit careful sometimes to talk about positive and negative emotions. Emotions are what they are. They're not good or bad. They just are. They're a part of us, and not judging and making it normal to talk about things like that. So I think normalizing and not judging things as good or bad in terms of our responses to things, I think is really important. Without meaning to, and I catch myself doing it. Ironically, I'm a big fan of positive psychology, but I believe in positive psychology, but I also challenge some of the language within it. So we think some of the narrative around that, around emotion and emotional regulation is important. And just touching on the last point as well, a couple of people in the chat, I think, hit the nail on the head about dealing with toxic individuals. It's Chris Turner's point around call it out with compassion. Mm-hmm. I think that hits the nail on the head for how we deal with that kind of thing. There's an awful lot of that in sport, and I won't rattle on at length about that. Dealing with the difficult mavericks in sport is a very interesting and tricky debate, and there's a lot of split opinion on it. But if anyone wants to have that at length.
Are you okay for one more question? I think this one's for you, Ben. Psychological safety begins in childhood and is learned from our parents. Stress or our responses learned from life experiences. Psychologists remain in supervision throughout their career to avoid emotional burnt out. Surgeons have people's lives in their hands every day. You mentioned about the role of coaches for surgeons. How would you envisage implementing a coaching role for doctors in the NHS? And should this become compulsory in the future so that the NHS has surgeons working at optimal performance and to avoid the cost of burnout and early retirement?
That's a really, really good question. And I totally understand. My mother's a counselling psychologist, and absolutely, as you say, has regular supervision all the time for that reason. even as a coach, you know, the same for me as well. How I think absolutely yes, there's a role for that. How we go about implementing it, I think it depends. Obviously, there's two ways of doing this. One is a kind of formal coach-coachee relationship type thing, and that's identifying people. And again, do we see coaching as more a mentoring approach, which is having identified someone in a senior role, someone with more experience as mentoring, but doing so using a coaching framework, which is essentially asking questions and helping people reach solutions for themselves, which is helps people generate more confidence than being told what to do. And that's one way. Or actually using people who are entirely separate from your environment, so they can't really advise you technically because they don't have the technical knowledge, but they're there as a kind of supportive sounding board, neutral person. There's a place for that, but that's obviously requires an awful lot of people skilled in coaching to do that. And that's time, that's resource, that's money. Will it happen for everybody forevermore? Unlikely. I think it should happen. I think it's unlikely to happen for everybody in the near future. I think what's probably more possible is helping more people who are in the position to be able to coach and support others to really develop coaching and mentoring skills, because it's a skill set in its own right. Teaching, coaching, training, mentoring, these are skill sets. I'm not sure we value them as much as we value the technical skills. We just assume that as people in any profession get more experience, they get good at supporting others to also develop experience. And the fact is, some people through their experiences become brilliant. Some people just are. They're through various mechanisms in their own experience. They're good listeners. They're empathic. They're non-judgmental, and that's because they probably had that from other people. And they just ought to, you know. But that's being good by luck. We just hope, you know. I might get lucky, and I have someone who kind of informally mentors me, who's brilliantly empathic, and that's really helpful. Or I might not. I might have. You know, Mike was describing, you know. I might have one of those very autocratic people that I answer to who's not very good. So I have a very different experience. So I prefer that we're good by design. And what that means is seeing the development of effective coaching, mentoring, training skills as an absolutely core part of professional development and not just surgeons, not just doctors, but throughout the, you know, how many managers in the NHS get really good quality formalized training? How many managers in the NHS get protected time for their own professional development? That's such a missing piece of this puzzle. You know, most consultants get protected time for development, but managers don't. And yet, how much moaning do we do about managers not being good managers? So I absolutely agree. But I think the implementation is probably multifactorial.
Thank you, Ben. I think it's time we draw the session to a conclusion. It's been a fascinating afternoon listening to various perspectives. I have to thank my faculty, Mike, Peter Brennan, my colleagues from across the pond, Caroline Moulton and Carter Labaris, and Ben, particularly the two professors from the States and Canada, because both of them had to get up early this morning because it's still morning in the East Coast and Pacific Coast. We would like to thank the background support from Emma, our educational administrator, who's pulled all the strings together, Ryan Lowry in the College of Surgeons, who has been the tech help setting up the webinar, Richard Stein, who's a surgical colleague, and dare I say, one of my mentors, who's been sitting there in the background, managing all the screens and computers. And on behalf of the Society for Cardiothoracic Surgery, we welcome you to the AGM and University, which starts tomorrow for the next 2 days. And finally, from the Surgical Specialty Board of Cardiothoracics for the Royal College of Surgeons of Edinburgh and the ACTS, a big thank you to you all. Have a lovely evening. Thank you.
Thank you.
Thank you.
Thanks. Bye.